How do you do? Manuensi, a woman walked close to me. She said, if you do me, I'll do you. So give it up for all the Ashanti region. Give it up for them. So next, we're going to, in the next 5 minutes, we're going to play a very short documentary of how far we have come. The achievements, the milestones, and all that has supported us this way. And mostly we know that this couldn't have been done without your lovely selves gathered here. So ladies and gentlemen, if you're ready, let's go. Action.
Hello, everyone. PSGAGS are finally here, and we are excited to have you here. So, in the past year, many of us have been doing wonderful things in our various facilities to ensure that child health care in Ghana is the optimum best. We have gone to some selected facilities in some regions to tell us what the success story has been in the past year. The later intensive training at the Eastern Regional Hospital. This is our special community. And so we are the little staff at the Eastern Regional Hospital, and we want to take you through our experience and our journey so far. So just to start with, I just want to say a very short history about. Yes. So this is from a very small area. It close at the line in Europe. Yes, we had two cubicles, and they were very small. We had one for our inward, and then we had one for our referral unit. But it was very small to the extent that we were nursing babies, about 20 to 30 babies. And it was so cumbersome because waiting for the babies, you see the mothers around giving feeds and breastfeeding their babies, and it was training our weight or making our baby. And then we also had a very small room for our KMC and adaptation units where mothers who had preterm babies will go and nurse their babies there, and then kangaroo mother care for them, as well as taking care of them and feeding them as well. I just want to say that from then, Nana Wadi promised to give us an ultra modern building that is solely for our weekly or for the babies, where we'll have the mother's hostel. Because if you can recollect, we had a mother's hostel, which was a very small structure, and the place was so packed that mothers couldn't even stay there or sleep over to come and take care of the babies there. So just to make things so simple and easy, we had to build an ultra-modern facility, which includes the KMC adaptation room, 4 cubicles, and the nurses hostel or a receptionist, and then a big hostel which was also friendly to accommodate all our mothers and make work so effective and efficient. So just come along with us as our colleagues there also quickly on. Let's see this because and corridor for the mothers to live in the breastfeeding. So initially at our old units or our old building, mothers were supposed to be inside the unit since our space was very small. So we have a time for our mothers where they prepare their meals and have a nice thing. They enjoy their thing together with grocery. Yes. We have a thoughtful way of mothers then to provide them a place to rest and relax so that they can be healthy for their babies. A healthy mother is a healthy.
I know Dr. Japanese, the senior specialist pediatrician and clinical coordinator for Holy Family Hospital. I also stand in as a chair for Pediatric Society. I am grateful to Pediatric Society for this opportunity for us to talk about what we do at our various facilities. Holy Family Hospital is a secondary level facility and also accredited by Ghana College of Physicians and Surgeons for residency and fellowship training in pediatrics and OBGYN. It is a 350-bed capacity, with pediatrics occupying 100 beds. We have a NICU that this has 40-bed capacity. And then we have the pediatric emergency unit that also takes 10 patients. And then we have also the pediatric ward, which is also about 40-bed capacity. We offer both inpatient and outpatient services. On the outpatient, we run the normal pediatric clinic, given run by physician assistants and medical officers and house officers. Then we run the specialist clinic also, and that run by specialists and medical officers. So we have special days for, we have a new pediatrician. There are 5 pediatricians in the facility. One is new pediatrician, and all the 4 are general, but currently 2, one is doing pediatric nephrology and another also specializing in pediatric infectious disease. So one of the challenges was coordination of referrals. That was a big challenge for us. So we had a stakeholders meeting and we drew some referral guidelines among ourselves. And this has been good. We sat down to have a meeting and drew guidelines to help us streamline referrals. And I believe this one will be successful. In previous, we realized there are cases we could even work together with the clinicians at the periphery and manage without even referring.
Hello. We are PSU volunteer.
Dr. Joan Ifowwood, a pediatrician who works at the Bank Hospital situated in the Greater Accra region. This facility has been in existence since April 2021, and so we've been operating for almost 4 years now. We have 8 registered nurses, 5 pediatric nurses, 1 neonatal nurse specialist, and 2 permanent pediatricians. The services we provide are our general OPD services, which we do Monday to Sunday. And then we have our inpatient services where our pediatricians see our patients, our surgical cases, and our NICU cases, they see them. We also have the specialist clinic running. We currently run asthma clinic. We have our sickle cell clinic running. And then we also have our postnatal. We have our NICU follow-up services also running. The adolescent clinic also will be starting very soon. We also have our immunization services also running.
Speaking of challenges, we've encountered a number of challenges as a facility. And the one I would like to highlight is actually a challenge that we are still facing, and which is the fact that our name, the Bank Hospital, serves as a deterrent to many people, the ordinary Ghanaians. Because a lot of people had the notion that it was, done for just the Bank of Ghana staff. But that is not the case. We are here to serve the nation, as our motto says. And really, we just want to bridge that gap between the social classes, middle income, high income society. And that is why we are here. So that has been a major challenge that we have faced over the past year. Another challenge that we face is the fact that we see people from diverse sociocultural backgrounds, not just Ghana, but Africa, even the world at large. And, people coming to our facilities with our expectation this high, and we have to do twice as much to ensure that we meet their expectations. But we were born for this. We were created for this. So we try as much as possible to meet the expectation of every single parent, every single patient that we see in our facility.
Our achievements. There's been a steady increase in both our pediatric and NICU patient numbers since we started in April
2021 to date. Currently, we see about 800 patients in the outpatient department alone every month. Our subspecialty clinics have also become fully established, especially with the asthma clinic, the sickle cell clinic, the NICU and postnatal follow-up clinics have become fully established. We have also had a great support from the Kolebu Teaching Hospital, PICU, as well as from the Greater Accra Regional Hospital, PICU. They have been of such great support to us over the past few years. For the past 1 year, we have also been accredited to be a residency training site for the Faculty of Pediatrics for both the Ghana College and the West Africa College of Physicians. Looking ahead, it looks very promising. We hope to establish our own PICU by the middle of this year and also to structure our residency program in a better way.
So to all our regions, we see you. We see the hard work you've put in to make sure that our children get the best of care in these regions. We say kudos to you. Continue, because next year, PSG AGSM, we know you would have more to offer us.
Thank you very much. Another round of applause, very lovely documentary. We have some more familiar faces that we'd like to acknowledge. We'd like to acknowledge our immediate past president of the Pediatric Society of Ghana, Dr. John Adebiapia, who is also the head of the Pediatric Intensive Care Unit. We are celebrating 10 years in existence. Thank you very much. We have with him his lovely wife, Dr. Lako Owusu-Apia, a wave. Dr. Vivian Pencil is also in our midst, all the way from Konfanoche, head of oncology unit. Thank you very much for coming.
Thank you very much, Dr. Kesura. And I also want to acknowledge earlier on when we came in, there was a fine lady behind that keyboard. She is Ghana's first trained music therapist, resident music therapist, UGMC, executive director of the Music Therapy Association of Ghana, and she's executive director of the Institute of Music Therapy Ghana. Ladies and gentlemen, please let us acknowledge Maria Okulu. She's in the house. Where's she? Okay, thank you. And so, before we take the address from Her Excellency, the First Lady of the Republic of Ghana and the representative, we will take a very quick cultural, you can say cultural performance from Tessa Cultural Group. Please, let's give it up for them as they cater to some very beautiful music. And if you feel like getting up to shake yourself, please do. Okay? with a needle. The guy injected, and I felt it from where I was standing. Can you imagine? My buttocks hurts. A round of applause for the cultural group once again. Give it up for them. And that reminded me of some injection that I was given somewhere around Mampoy Kwapim. Thank you so much, lovely doctors, nurses, physiotherapists, and all health workers gathered here. We are proud of the good work you have done so far as children are concerned. Once again, please, a round of applause for yourselves. You deserve it. So kindly help me. Let me acknowledge these guests in our midst. Please allow me some of the names. If you have not eaten banku and okro, you cannot mention them well. So be patient with me. So I can acknowledge the representative for our Honorable Minister of Health, who we had, Dr. Hafiz Adam. Thank you very much. Simpi Newtown Sukai Queen Mother. Na Adole Ablade the first. Wong penye kemba biene. Nye fifo wa denchele bine. Actually, we want to acknowledge Akle Kwemi. Oboshi Aki the first. Adabaka Nene Kwapro Ajoyi. Watch Adwale. Owado. I also want to acknowledge Nwa Akwashi Ni Akwe Dankwa the fifth. The head of the National Blood Service, Dr. Shelley Phyllis Sufori. You're also here. A round of applause for yourselves. It's time for us to introduce the representative of our keynote and our guest speaker, Her Excellency, the First Lady of the Republic of Ghana. And we need a profile of the representative here in our midst. She's a highly experienced social worker with over 15 years of post-qualifying experience with children's service across the UK and Ghana. She has built a distinguished career in social work, specializing in child protection, family assessment, and adoption and fostering support. With a steadfast commitment to promoting positive change and achieving the best outcomes for children, adults, and families. In addition to her career in social work, she is an accomplished entrepreneur who has successfully founded and led an international migration company specialized in work and study abroad opportunities. Ladies and gentlemen, this lady looks very cute, but she has a very big profile. Without much ado, please a round of applause. Let's welcome Madam Isla Sancho Dokwa. Let's give it up for her.
Thank you very much, MC. I forgot to add that I'm also the board secretary for Lodina Foundation. Thank you. Good morning, distinguished members of the Pediatric Association, esteemed colleagues, honored guests, Nimen Namin, cherished friends, ladies and gentlemen. It is a profound honor for me to represent my mother and my boss, the First Lady of the Republic of Ghana and President of the Lodina Foundation, Her Excellency Lodina Dramani Mahama, at this significant event. Her Excellency extends her warmest greetings to the leadership and members of the Pediatric Society of Ghana. She wishes to convey that she considers herself a member of your esteemed family and always look forward to participating in your annual general meeting. Regrettably, she's unable to be here in person today to another equally important commitment. But the truth is, her heart is with us. The Lodina Foundation has been a major advocate for women and children's healthcare for the past 2 decades, with a special focus on providing maternal and postnatal healthcare support to the women and children in rural and undeserved communities in Ghana. The foundation has embarked on several life-changing projects, including the construction of signature Lodina Foundation Maternity and Children's Ward in Bole, in Kranza South, and Bodom, as well as the renovation and expansion of the Adabraka Health Center in Hohoi, located in the Volta region of Ghana. The theme for the Pediatric Society of Ghana 2025 Annual General Scientific Meeting is Bridging Gaps and Building Resilience in Child Healthcare Delivery across Ghana. It aligns perfectly with our core vision to bridge the gap between the disadvantaged and the privileged by providing marginalized groups and communities with equal opportunities. The gaps in healthcare delivery are multifaceted, encompassing geographical, economic, and social dimensions. Children in remote areas often face barriers to accessing essential services, leading to preventable diseases and unnecessary suffering. Additionally, socioeconomic factors, including poverty and education, create disparities that hinder equitable healthcare delivery. It is regrettable and unfortunate to witness pregnant women in labor being transported on motorbikes and tricycles to non-existent hospital facilities with no medical equipment or health professionals available. Furthermore, immunization rates have declined due to a recent shortage of crucial vaccines, exposing many innocent children to risk and unforeseen dangers. As pediatricians, nurses, and healthcare professionals, it is our duty to recognize these gaps and work collaboratively to bridge them. This requires innovative solutions, community engagement, and a commitment to advocacy. We must leverage technology to improve access to information and services, train community healthcare workers, and strengthen partnership with local organizations to ensure that every child, regardless of their circumstances, has access to quality healthcare. Building resilience in child healthcare delivery is not just about addressing immediate gaps. It is also about creating a sustainable framework that can withstand future challenges. The COVID-19 pandemic has taught us that invaluable lessons about the importance of resilience. It has highlighted vulnerabilities in our healthcare systems and the urgent need for preparedness. We must prioritize the integration of mental health services into pediatric care. We also have to recognize that the well-being of our children extends beyond physical health. We need to foster environments where children can thrive, environments that support their emotional, psychological, and social development. Moreover, building resilience means investing in training and well-being of our healthcare workforce. Our healthcare work professionals are our greatest assets, and they must be supported, valued, and equipped with the tools they need to provide the best care possible. In recent years, we have witnessed significant strides in child health care. Maternal and child mortality rates have declined, and access to basic healthcare services has expanded. Yet, we cannot ignore the disparities that exist, particularly in rural and undeserved communities. The Lodina Foundation, as a dedicated non-governmental organization, is committed to preserving the lives of women and children in these communities. Our mission is to address the critical issues of discrimination and inequality within our society. In pursuit of this vision, we have initiated a series of healthcare donation programs, collaborating various healthcare facilities across the country. Through these initiatives, we have successfully distributed hundreds of medical equipment and supplies, including incubators, electronic theater beds, delivery beds, mobile ultrasound machines, ECG machines, physiotherapy equipment, electric suction units, digital weighing scales, baby cots, baby cribs, boxes of latex gloves, and syringes. Our aim here is to ensure that quality healthcare is accessible to all individuals, transcending geographical and demographic barriers, and affirming that it is a fundamental right for every citizen, not just a privilege for the affluent or those residing in urban areas. In light of this, it is our firm hope that the government of His Excellency John Dramani Mahama will introduce deliberate and innovative policy measures in the healthcare sector to address the yawning gap in healthcare delivery between urban cities and rural communities. As we engage in our discussions today, as we share our research and explore innovative practices during this meeting, I urge you all, each of you, to consider how you can contribute to bridging gaps and building resilience in child health care delivery. Let us challenge ourselves to think beyond our individual practices and collaborate across disciplines, communities, and sectors. Together, we can advocate for policy changes that prioritize child health. We can also invest in research that addresses our unique challenges and foster a culture of continuous learning and improvement. We look forward to a day when a child in a small community in any village in Ghana receives the same quality healthcare services as a child born in cantonments or airport in Accra. We anticipate a future which a vulnerable mother residing in a rural community can embrace her child with the assurance of having access to healthcare facilities. In such a scenario, the air will be filled with hope and relief, alleviating the fear of losing a child to a minor illness. Until then, our advocacy for equality and the need to bridge gaps and build resilience in child healthcare delivery across Ghana will not rest. Our founder, the board, and the management of Lodina Foundation, we look forward to more collaborative initiatives with the Pediatric Society of Ghana in preserving and promoting child healthcare in Ghana and beyond. We trust that with your expertise and experience in providing quality healthcare for children, we can build the bridge needed to eliminate barriers and gaps. It is through our dedication that we can envision a future where every child in Ghana has the opportunity to grow, thrive, and reach their full potential. We wish you all the best with the reminder of your programs and pray that you have a successful and productive annual general and science meeting. Thank you very much.
Let's give it up for her once again. I was giving you fans earlier on that you clap out. Clap for me, clap for me. Thank you so much, Madam Priscilla. Awesome one. Thank you. Thank you. Please, when you go, our regards to Her Excellency, the First Lady. Thank you very much. Okay, thank you very much. Please allow me to acknowledge Director, Family Health Division, Ghana Health Service, Dr. Marion Oko Owusu.
Also acknowledge the former Director General of the Ghana Health Service, Dr. Kuma Abuaji. Coming all the way from Tamale is Professor Mumin. Thank you for being here with us. We also have in our presence our very own Head of Department of Child Health, Akomfanoche, Professor Samson Enchi. We have some video messages of solidarity that we're going to be playing next. Thank you very much and enjoy.
Thank you very much. And Kesewa, I need to introduce myself well because when everybody's addressing you, they say Dr. Kesewa. But when it comes to me, they say MC. Can I please introduce myself? My name is Dr. Frank Okante. Oh, come on, give it up for me. But my doctor is a native doctor. That's not that one. Thank you very much. Shall we please take some messages on our screen right there? Thank you so much.
My name is Dr. Supa Tunje. I'm the chair of Kenya Pediatric Association. Distinguished colleagues in Ghana, it is a great honor to address this esteemed gathering of pediatric professionals as we discuss universal health coverage. UHC is not merely a policy goal, it is a moral imperative. It is a fundamental right of every child to access quality healthcare regardless of their socioeconomic background. As pediatricians, we have a vital role to play in advocating for UHC, in increased investment in child health, championing quality improvement initiatives, educating the public, and also through collaborations with other stakeholders to be able to implement UHC. UHC is not just a dream, it is an achievable goal. I wish you fruitful deliberations as you champion for quality healthcare for the children of Ghana and Africa at large. Thank you and God bless you all. Asanteni sana.
Akwaba, on behalf of the Pediatric Association of Nigeria, PAN, I extend warm greetings and heartfelt solidarity to the Ghana Pediatric Society on the occasion of your 2025 Annual General and Scientific Meeting. I also congratulate you on the recent successful inauguration of John Mahama as the new president of Ghana. The theme of your conference, Universal Health Coverage, Bridging Gaps and Building Resilience in Child Healthcare Delivery across Ghana, resonates deeply with the shared aspirations of pediatricians across Africa. It highlights the urgent need to ensure equitable access to quality health care for every child, irrespective of their socioeconomic background or geographical location. As colleagues united in our commitment to advancing the health and well-being of children, we recognize the critical importance of universal health coverage in addressing disparities, enhancing service delivery, and fostering resilience within our healthcare systems. The Pediatric Association of Nigeria stands with you in your efforts to bridge these gaps and achieve sustainable progress in child healthcare delivery. May your deliberations during this AGSM inspire innovative strategies, strengthen partnerships, and motivate actions that will not only benefit children in Ghana, but also serve as a model for our region. As we navigate shared challenges, let us continue to collaborate, exchange knowledge, and work towards a future where every child in Africa can thrive. We wish you a successful and impactful meeting and look forward to continued collaboration between our societies in the pursuit of a healthier future for all children. Mesdames, Moissy.
Hello, everyone. I am Dr. Naveen Thakkar, President of International Pediatric Association, and I am very happy to join you today virtually, as I could not be there, to wish you best wishes and a very successful conference of Pediatric Society of Ghana, who is a very important and very active member of International Pediatric Association. International Pediatric Association is 115 years old, umbrella organization of all pediatricians, more than 1 million pediatricians of the world. And we are very proud to have Ghana Pediatric Society as our very active member and currently very ably led by Dr. Hilda. So I wish Dr. Hilda and Dr. Beatrice a very successful conference. I am not able to be there, but my best wishes are with you. The theme this year is universal health coverage, bridging gaps and building resilience in child health care delivery across Ghana. And this is a very appropriate theme, and it is very important to bridge gaps and build resilience. And I hope deliberations of this conference will be very useful, and we look forward to receive your recommendation. I invite you, all of you, for the IPA Congress 2025, which will be held in Mexico City from 8th to 11th of May. Please join us, where more than 100 pediatric society of the world will join. Again, thank you, Dr. Hilda, and thank you, Dr. Beatrice, and best wishes from my side. Thank you.
First things you learn as a newly minted doctor on the ward is that when you start work is that the ward belongs to the nurses. The ward belongs to the nurses. And we are so proud and happy to have them as part of the members of the Pediatric Association of Ghana. Can we give them a hand of applause? We will take a solidarity message from the representative of Ghana Registered Nurses Association. She said, if you can please kindly come up for the message.
Honorable guests, distinguished colleagues, esteemed members of the Pediatric Society Ghana, ladies and gentlemen, permit me to stand on the existing protocols. It is a honor to stand here before you to bring you warm greetings from the Ghana Registered Nurses and Midwives Association of Ghana, representing the Pediatric Nurses Society of Ghana, which is under the main umbrella, GRMA, to discuss a topic that is very central to a collaborative decision, universal health coverage and its role in bridging gaps and building resilience in Ghana healthcare across the country. As pediatric healthcare professionals, we are at the front of ensuring that no child is left behind in accepting quality, affordable, and equitable healthcare services. Children are among the most vulnerable members of our society, and their well-being is a direct indicator of the strength of healthier care system. Despite the effort to improve healthcare delivery, many Ghanaian children still face barriers to access including geographical disparities, financial constraints, workforce shortage, and limitation in essential medicines and technology. Universal health coverage is not just a goal, it is a commitment in ensuring that every child, regardless of the socio-demographic or economic background, receives timely and equitable health care without suffering from financial hardship. The Sustainable Development Goal, specifically the SDG 683, calls for achieving with a focus on reducing infant and child mortality, ensuring immunization coverage, and strengthening the healthcare infrastructure. Resilience in child healthcare means that our health system are very adaptive, sustainable, responsive to emerging threats such as disease outbreak, climate change, and economic crisis. Strengthening primary healthcare facilities with modern equipment, neonatal units, and essential medicine is crucial for ensuring quality pediatric services. Digital health solutions, electronic medical records, and mobile health intervention can improve service delivery, reducing the disparities and enhancing data-driven decision-making. Collaborative between government agencies, private healthcare providers, and international health organizations can also drive innovative solutions in pediatric care and financing. Our call of action as pediatric healthcare professionals, we have an ethical and professional responsibility at the front side of advocacy and implementation. So today, we call upon the government and our policymakers to spotlight the child health care services with the UHC agenda by expanding the NHIS coverage, investing pediatric trainings, improving rural healthcare infrastructure. To commitment to continual learning, mentorship, and advocacy for child health policies that ensure equitable quality care services for the Ghanaian children. To partner in preventive care, ensuring children receive vaccinations, proper nutrition, and early medical attention when needed. In conclusion, achieving the universal health coverage for children in Ghana is within our very much reach. By bridging gaps in accessing, financing, and healthcare workforce development whilst building resilience in service delivery, we can lay the foundation for a healthier future for every child. Let us work together, policymakers, healthcare providers, and communities to transform child healthcare delivery in Ghana and ensure that no child is left behind. Thank you. We continue to serve, heal, and advocate for the future of Ghanaian children. May God bless us all.
Please, let's appreciate them once again. Thank you. And it's time for us to take a very quick musical interlude by Mawuyami Oklu. Let's give it up for her as she gives us that.
Good morning. Thank you very much for this opportunity. So music has a very interesting way of bridging the gap, okay? It brings together different distinct styles. And you may be a doctor working somewhere in a hospital, doing your part, just keeping on working with clients. Then there's another doctor in another hospital doing her part or his part, just working. And then another doctor joins from wherever they are in another region. But the beauty of bridging the gap is when you all come together and you do what you do your best. And that brings everybody together. So the next song you're going to hear is a beautiful song. And we're used to listening to music with our eyes open. I know that. But I would encourage you for a change to listen with your eyes closed and just to relax and enjoy the sounds of the music. So let's keep on singing. For this. As a doctor, you get stressed and tensed, trying to solve just sent home. Have an attitude of gratitude. See what
So while we are alive, two, we can hear. Three, you can see me, and you can hear. So
Wow. If I had this, your voice back in school, I'm sure my music teacher would have liked me. People, I'm not kidding. Anytime my music teacher comes to class, she'll ask us to do, come on, let's do this together. Do, re, mi, fa. It's possible called Saito. Then the correct Saito, those who do morning and afternoon shift, the teacher will ask you to reverse it. So let's go. Themselves. You all went to Saito. You're looking fine like you went to university outside the country. I like that. I like that. I'm so happy. And so before we take the keynote address, please help me, or let's acknowledge these wonderful people in our midst. Professor of the School of Public Health, Legon, Mr. Alexander Menu. You're here. A round of applause for him. Professor Alexander Menu. Then we also have here Deputy Director, Information Monitoring and Evaluation for PPMED, the Ghana Health Service, Dr. Salamatu Atta Nantogma. Let's give it up for her. Wow. Often when you see a long name, powerful name, you want to see the personality behind it. And normally they are very cute. Let's give it up for her once again. So it's time for us to hear the keynote address on the theme, Universal Health Coverage, Bridging Gap and Building Resilience in Child Healthcare Delivery across Ghana. And ladies and gentlemen, this morning, we are privileged to have an accomplished consultant in the neurosurgeon. He is passionate about patient care and safety. Previously, he served as a director of the Institutional Care Divisional of the Ghana Health Service and led his team to implement various innovative strategies to advance the health system. With a round of applause, please help me. Let's welcome Professor Samuel Kaba Akoriwe.
All right, thank you so very much, MC. Good morning, everybody. I think I'm getting old, is it? Madam Chairwoman, Chiefs and Queen Mothers, the immediate past Director General, Dr. Kumar Boaji, the representative of the Minister, colleagues, the media present, ladies and gentlemen. If I'm also permitted, I'll say fellow Ghanaians. Today marks a very important day in the calendar of the members of the Pediatric Society of Ghana. This year's theme is universal health coverage, bridging the gaps and building resilience in child healthcare delivery across the country. And I will start by telling you a story. 53 years ago, in a remote village in this country, there were no doctors, there were no nurses. A child was born, just as many children were delivered. Some lost their lives and some survived. It took his mother 9 days to walk to another village to get him registered in a clinic for the first time. His parents poured so much into him, hoping that one day he too will count. And that child today is the person standing before you to give the keynote address. And this is what it means, that if a child dies in this country without growing to the adulthood, that makes our life poorer. If a lady goes to the bank, the lady delivers and dies, the child dies, that makes us poorer. Because that child could have been the next acting director general, could have been you, the pediatricians, and could have been the next minister or even the president of this country, or the next Kofi Annan that we'll be proud of, or the next scientist to discover the treatment for malaria. Or that child can simply be the child who roof your houses, the farmer who put food on our tables, or the person who cleans our offices early in the morning for us to be safe. Every child counts. And so for me, seeing this place full of pediatricians makes me happy. Makes me extremely happy, because I never had that chance to meet a pediatrician when I was a kid. And I want to say, Madam Chairwoman, my office is your office. I look forward to collaborating with you and the entire team for us to forge forward and make every child in this country survive. Thank you so very much. Now, according to WHO, universal health coverage simply means that all people have access to the full range of quality health services they need, when and where they need them, without any financial hardship. This covers the full continuum of essential health services, from health promotion to prevention, treatment, rehabilitation, and palliative care across the life course. So far, the world is off track to make significant progress towards universal health coverage. Improvements to health service coverage have stagnated since 2015. And the proportion of the population that face catastrophic levels of out-of-pocket health spending increased continuously since 2000. The coverage index increased from 45 to 68 between 2000 and 2021. However, recent progress in increasing coverage has slowed compared to pre-2015, rising only 3 index points between 2015 and 2021, and showing no change since 2019. Ghana is committed to attaining the initiatives of universal health coverage and the political declaration adopted at the UN high-level meeting September 2019. At the heart of this are the principles of human rights, equity, gender, and people-centered approaches. The country over the years has undergone several health sector reforms aimed to improve health outcomes. The current national health policy emphasizes systems strengthening, improving service availability for the population, through community health services and expansion of public health interventions. The social health insurance scheme has also been introduced to reduce expenditure, particularly for the poor and the vulnerable. Ghana defines universal health coverage as all people in Ghana have timely access to high quality health services, irrespective of ability to pay at the point of use. And our goal is to increase access to quality essential healthcare and population-based services for all by 2030. The following objectives have therefore been constructed to help in achieving universal health coverage. 1, universal access to better and efficient quality healthcare services. 2, reduce unnecessary maternal, adolescent, and child deaths and disabilities. And 3, increase access to responsive clinical and public health emergency services. Building resilience requires a collaborative approach. We will deepen our partnership established under the SDGs Global Action Plan. We will actively engage the private sector by incentivizing service provision in underserved regions. Community empowerment through training local health volunteers and integrating traditional leaders into primary health care shall all be our objectives. As we move forward, let us remember that universal health coverage is a continuous journey, building on the focus on quality healthcare as a catalyst from the 2024 Health Summit. Equity, innovation, and accountability will guide our efforts to ensure no child in Ghana is left behind. Let this decade be remembered for transforming gaps into bridges and fragility into enduring resilience for the health of all our children. Thank you so very much, everybody. God bless us all.
Thank you very much. Another hand of applause for him. Pediatric Society of Ghana is a teamwork. As we said before, we are made up of doctors, nurses, physiotherapists, respiratory therapists, and hopefully very soon we'll have some music therapy on board. This program would not have been successful without our proud sponsors. We'd like to acknowledge Sanofi. We'd also like to acknowledge Novartis Ghana and also Philips Ghana. Please kindly give them a round of applause for their support. Up next, we'll have a short music interlude, after which we'll have a citation presentation.
A round of applause for Madam Oklu. Let's give it up for her once again. And I've been informed to trust and obey. So I'm going to trust and obey. And in my obedience, please help me with a round of applause. Let's call upon the president, the national president of PSG Ghana, and the chairperson, Dr. Hilda Montibia Boy, to take over now and run us through some little activity. Let's give it up for her as she comes in.
I won't do this alone. We just have a special activity to do. It's a special presentation. So we'll call Prof Welbeck, Dr. Prof. Goka, Dr. Segomoses to join. Dr. Jasai, executives available, you may join on stage. LOC Chair, Dr. Debbie Apia. Shall we have citation, please? So shall we call Dr. Patrick Kumar Buaji? Immediate past Director General of the Ghana Health Service.
Sorry.
Can you increase your claps for? Okay, so I remember that when we took up office and we started our courtesy calls, Dr. Kofi Issa, I don't know if he's here, Family Health Director of the Ghana Health Service at the time, he held our hands and we went to see Dr. Kumar Buaji. And we had very fruitful deliberations. Actually, the theme for today sort of came from our conversations that we had with him. And we are so grateful for all that he's done together with the Ghana Health Service to support us. So permit me to read. This is a citation of honor for Dr. Patrick Kumar Abuaji. In recognition of your outstanding leadership and exceptional contributions to the advancement of child health in Ghana. As the immediate past Director General of the Ghana Health Service, you have been at the forefront of policies and programs that have significantly improved maternal and child health outcomes across the country, leaving a lasting legacy in child health care delivery. Your dedication to expanding immunization coverage, reducing neonatal mortality, and combating malnutrition has led to measurable improvements in the health and well-being of Ghana's children. Many children are smiling today because of some of your initiatives, such as the introduction of the new malaria vaccine and the scaling up of essential newborn care. Your work has directly impacted the lives of countless children across Ghana. Your unwavering support for the Pediatric Society of Ghana has fostered a thriving partnership with the Ghana Health Service through the Family Health Division. This, over the years, has strengthened our advocacy activities, giving our society the needed recognition and support to push the child health agenda in Ghana. The Pediatric Society of Ghana proudly honors your extraordinary achievements and remarkable legacy in advancing child health in Ghana. So someone might say that, well, wasn't he doing his job? Yes, he was, but he did it with so much grace and dedication, and we applaud him. Thank you very much. So Dr. Segomoses, who is the chairperson for our awards committee, will do the presentation with our support. Thank you.
Thank you very much. Madam Representative of the First Lady, my colleague and my immediate successor, Professor Akore Kaba, Nime Name. It's been privilege and honor being called here at the surprise to receive this award. I want to thank you all for the support. I want to thank my directors. I want to thank everybody, chiefs, everybody who helped us in the difficult times to ensure that we put the child first. I'm also grateful for the Pediatric Society for being there and being an advocate and actually pushing out to make sure that child health becomes an important aspect of the health of this country. I want to use the opportunity once again to thank you all. And I'm sure that I'll continue in my best way, in any form, to support child health in this country, wherever I find myself. Thank you very much.
So I've pulled Dr. Emmanuel upon to join me so that we do the closing remarks. I didn't write. I was so excited enjoying the music and the dance and the needles and everything. So if I forget anything, I hope you remind me. All right. So I think you'll agree with me that it's been a beautiful program. The start wasn't quite on time. I know our teachers will be marking us, but then we hope that we've been able to close in time for the other activities to continue. We heard from our key partners, the Ghana Health Service, the Ministry of Health. We also heard from the First Lady. They have assured us that they are going to be with us and support us. We have other partners, the USAID, the Kibeli, UNICEF, and then our other sponsors and partners, local and other local and international NGOs. And they have all assured us that they are going to support us as we work towards achieving universal health coverage. You may also have noticed that we've started doing a bit more on the adolescent health. So that will also feature strongly in the program.
And yes, we'll continue to focus on making sure that our newborn mortality and morbidity issues are addressed. Birth asphyxia, prematurity, and infections in newborns still remain a key aspect of our child health and newborn issues. And we are very happy to have our partners with us to address them this year and going forward. Thank you.
So when I was writing the speech, Dr. Daniel said that definitely this year we have to take a pledge. So ladies and gentlemen, kindly be on your feet and let's take a pledge for universal health coverage. So it will be very simple. You put your hand on your chest and then you can say after me, I, then you mention your name. I pledge to do everything I can to support government and Pediatric Society and its partners' efforts to attain the universal health coverage for all children in Ghana. So help me God. Ladies and gentlemen, you have earned the end of the first session. Enjoy the rest of the conference. Thank you so much.
President.
And ladies and gentlemen, thank you. Thank you very much. Soon we're going to assemble to take some group photographs. But before that, we want to say a big thank you to our partners.
Okay. So our headline sponsors: Sanofi, Novartis, Ghana, Abbott, Epifarm. Thank you very much for sponsoring us. Phase Pharma, Mega, Pharma for Access, Home Med, Enterprise, Panacea, SNF, Meditel, ICANN Institute, GE Ghana, BD, Kempinski, Pinnacle, and Cipla Respiratory.
And our partners for this lovely event has been Nabraka, USA, the WHO, UGMC, CHOP, Chebele Ghana, AHS and Notch Technologies, GMA, GES, and our media partners, UTV, Atom FM, GNA, Daily Graphic, and GH1. Thank you very much.
So if we can all come, the chiefs, if you can all kindly please move towards the stage. Our invited dignitaries and the chiefs, please kindly move forward as we take a photograph.
And as we are taking the photographs, we want you to know that our headline sponsor, Sanofi, is right behind you. Kindly have a word with them, pass through because they want to engage you and take your lovely feedbacks. And in your shot, as you see, our beautiful traditional leaders, Nime, Name, who have graced this wonderful occasion, looking all lovely and patriotic in their traditional regalias. Nime, Name, Yabawu Nyese Shinyahawo, Koni Nofiana Fe Fine. Our traditional leaders who have graced this lovely event, Nime, Name, in your pictures right now. Kindly do well to engage our sponsors who are behind us. Sanofi and the team behind you want to engage you, so please make time to engage them appropriately.
I'll be there for conference.
We're being reminded of the poster presentations. So please, if you are presenting, kindly be closer to your presentation. Thank you. All presenters for the poster presentations, please kindly get closer to your posters. Thank you.
And I want to believe that we are done. We've been standing for a long time looking at you. We don't see anything. Anyway, thank you so much. Thank you so much. And for your information, all our dignitaries, all our new as soon as you exit, kindly take your left. We are inviting all of you there for a very quick refreshment. And the rest of us, we can be at the alley as we get ready for the next session. Thank you very much. And see you soon after the break.
Agsm different.
Agsm combines protection against 6 diseases in a single injection: diphtheria, tetanus, whooping cough, hepatitis B, polio, and Haemophilus influenza E type B. For preterm babies, particularly advantageous because it contains a cellular pertussis component instead of the whole.
Thank you. Can we please invite all the partners among us to please come forward? We want to do a very nice picture. Ghana Health Service Director General, WHO. US. Right. So all the partners in the house, I believe yourselves can join us right now. And let's take some beautiful pictures. As today happens to be a very memorable day.
But also highly effective in providing immunity. For preterm babies like Toby, who may have a weaker immune system, the approach reduces the risk of severe reactions while ensuring strong protection against these diseases.
That's reassuring, doctor. So this will also help me keep up with his vaccination schedule?
Absolutely. With fewer side effects, parents feel more confident in bringing their children for subsequent doses. This improves overall compliance and ensures the child is fully protected.
Thank you, doctor. I'll go ahead with Agsm for Toby.
You're making an excellent choice for his health. Let Nurse Busy know, and she'll prepare everything.
C'était vraiment la chose la plus importante quand j'ai contracté cette méningite. Chaque fois, on imagine quelque chose de très compliqué, des hospitalisations difficiles, etc. Mais grâce à mes proches, grâce à mes parents, grâce à mon entourage, j'ai su mettre les choses négatives d'un côté et de penser qu'aux choses positives. Ce qui est important de savoir sur la méningite, c'est que c'est une maladie qui peut toucher des bébés, des enfants, mais pas que. Les adultes aussi peuvent la contracter. Et du coup, il faut faire attention toute sa vie. Ça. Une des choses les plus importantes aussi sur cette maladie, à mes yeux, c'est la rapidité qu'on doit avoir quand on ressent les premiers symptômes. C'est une véritable course contre la montre, donc il ne faut vraiment pas perdre de temps et aller voir absolument un médecin.
And in your shot, you see all our lovely partners who have come to support us. Thank you very much. And after this shot, we're inviting everyone in the hall to please move forward.
Morning, doctor.
And let's take one big, beautiful picture together.
I know how busy your clinic
As we are doing that,
Good morning.
calling all our dignitaries to please,
How can I help?
as soon as you take out of this hall,
Here to
you take the first left,
the fully
and we need in one of the rooms for a very special session.
protection against
Thank you so much, partners.
diphtheria,
Can we have everybody in the hall join us right here?
poliomyelitis,
The ladies,
Haemophilus influenzae type B,
please join us,
B.
and let's do one big photograph right here.
But we've been using other
Thank you.
vaccines for years. What makes Agsm different? That's a great question, doctor. Agsm is the first fully liquid hexavalent vaccine, which means no reconstitution is required. This minimizes preparation errors and contamination risks. Additionally, it includes a cellular pertussis.
Dr. Kotomoti,
Cell pertussis found in older
Dr.
vaccines.
Minta, please kindly join us.
A
Dr.
cellular pertussis.
Rosemont Kokro.
How's that better? A cellular
Doctors, nurses,
significantly reduces reaction
and all our medical practitioners in the house, please join us this way. Let's do one big picture to represent that we were also here.
With Hexaxim, these side effects are
Medical practitioners from the regions, Ashanti region, the northern region.
That's crucial. Many parents here delay or skip subsequent doses due to fear of side effects. Exactly, Doc. Hexaxim safety profile ensures more children complete their vaccination schedule.
Dr. Teria.
This is especially beneficial for preterm babies who are more vulnerable. The vaccine's efficacy and safety are well documented even in this population. Preterm babies are a delicate group. If Hexaxim offers better protection with fewer risks, it could make a significant difference. That's our goal. And because it's hexavalent, Hexaxim reduces the number of injections required, making vaccination less stressful for both babies and parents. Thank you, Mr. Bruce. I'll certainly consider introducing Hexaxim to our practice. Let me review the data you've provided. Thank you, Doctor. I'm confident you'll see its value. I'll be available for any questions or training your staff might need.
Can't waste the time. Yeah, we'll just take a picture.
Good morning, Nurse Abina. I hope I'm not interrupting.
Not at all. We're just getting ready for the morning rush. How can I assist you?
I wanted to share some information about Hexaxim, a vaccine that could make your job easier and improve the experience for our patients.
I'm listening. What's special about Hexaxim?
Hexaxim protects against 6 diseases in one shot. It's fully liquid, so no reconstitution is needed. That saves time and reduces errors. And it uses a cellular pertussis, which means fewer side effects like fever and swelling.
Fewer side effects would certainly reassure mothers. Just last week, a parent refused a second dose because her baby had a high fever after the first.
That's exactly the problem Hexaxim addresses. And for preterm babies who are already at risk, Hexaxim provides comprehensive protection without overwhelming their immune systems.
Excuse me, Nurse Abina. Is this vaccine safe for my baby? She was born prematurely. Mr. Asari, would you like to explain?
Certainly. Madam, Hexaxim has been proven safe and effective for preterm babies. It not only protects them from serious diseases, but also minimizes side effects, ensuring they remain comfortable after vaccination.
That's a relief. I want to give her the best protection possible. Thank you, Mr. Asare. I'll discuss this with Dr. Adesanya. Hexaxim sounds like a great addition to our practice.
Thank you, Nurse Abina. I'm here to support your team in any way I can.
WHO defines preterm as any live birth occurring before 37 weeks of gestation. Every year, on average 11% of babies around the world, or 15 million, are born premature. Preterm infants are at a higher risk of infections due to the immaturity of their immunological defense mechanisms. Despite this increased risk of infectious disease, vaccination of premature infants are often delayed. Instead, preterm infants should be vaccinated using the same schedules as full-term infants. Real-world surveillance of adverse events after hexavalent combination acellular pertussis vaccination in preterm infants shows a very similar profile to what was reported in term infants in clinical trials. Most injection site and systemic adverse events were reported at the same or lower frequency, with the exception of slightly higher frequency of induration, nodule and rash. No vomiting and no serious adverse event.
the wholesale pertussis that we previously had. When it comes to vaccines, we are always concerned about the safety profile, especially when it comes to our neonates. And so there were various studies that were done, including a meta-analysis for 20 different clinical trials. And what they realized that even when it came to the mild effect of the vaccines that we had, the acellular pertussis actually exhibited less side effects or adverse events in terms of vaccinology compared to the wholesale. So with the fevers, we all know how our mothers are very worried when they have vaccinations and the children get fevers, and they're very worried about that. So in terms of the fevers, when you had the wholesale pertussis, it was about 47% as compared to just 6% for the acellular pertussis. Same with irritability and same with anorexia. And when it came to serious adverse events, these hardly occur. But then when comparatively, when you compare the acellular pertussis to the wholesale, you realize that side effects like convulsions or adverse events like convulsions were seen more with the wholesale pertussis compared to the acellular pertussis. So this is a study that was also done looking at the side or the adverse events that I just mentioned about. And in terms of the study that was done, you realize that in Canada, there was a massive decrease with the side effects of the acellular pertussis compared to the wholesale that they actually also were using previously. So due to the reactogenicity of some of these vaccines that comes with the adverse events, there's always that drawback, and then you also have vaccine hesitancy. So every mother who's had a child who's ever reacted very badly to any of the vaccines wouldn't be happy to go for the second and the third. And studies have actually shown that if there's a population where you have more adverse events following vaccination, then there is always that hesitancy, and then your vaccine coverage will actually reduce. So the study that was done in Sao Paulo actually showed that for vaccination for those who never had any reaction at all, compared to those who had a reaction for the first vaccination that they had, there was about a 20% decrease. So it also reiterates the fact that we need to go for vaccines that are less reactogenic so that our vaccine coverage rate would also improve. Effectiveness was also compared for the acellular pertussis and the wholesale pertussis. And that efficacy for the wholesale vaccine was very variable. So it varied from about 36% to 96%. And with time, it actually dwindled, just like as we've seen in the Netherlands situation, where there's a decrease in the effectiveness of the vaccine over the time, compared from 1982 to about 1996. So this is a comparison of the acellular pertussis that's currently being used by most of the countries. And we realize that it has a very high efficacy of about 71 to 93%. And if you look at the Swedish experience, realize that prior to the vaccination, they were having quite a number of cases of pertussis per 100,000 population. Now they introduced the wholesale pertussis, it came down a bit, but then due to dwindling or the waning nature of the vaccine, they started having an increase in pertussis cases again, till they changed from wholesale pertussis to acellular pertussis. And that you can see their numbers have really come down in terms of the number of pertussis cases they are seeing per 100,000 population. So the duration of the protection, luckily, or the good thing about the acellular pertussis compared to the wholesale pertussis is that their protection is almost the same. So if you look at the two that are presented here, you realize that the slopes are almost the same. So it's not like we are losing protection by introducing acellular pertussis, but it's quite comparable, apart from the other advantages that it comes with as acellular pertussis. Now, most of these vaccines will come with a combination, and there's always an advantage of a combination as compared to just giving single vaccines at different times. So for the children, there's less pain for them. There are less or fewer side effects or adverse events compared to if you have to give single vaccines. For the parents, fewer visits, no stories of Juma and all that. At least they come once in a while, they get it, and then it's done. For the doctors and the nurses and advocates, for those of us who work with them, There's increased safety for us because you have less work to do. There's also improved clinical practice and efficiency. So our preterms are not left out when it comes to the acellular pertussis. They are equally safe, and various studies have shown that they are safe to be used. And all these academies, American Academy of Pediatrics, Italian Society of Pediatrics, they are all happy for this vaccine, acellular pertussis vaccine, to be used. And as I said, most of these countries are now using the acellular pertussis because of its advantages over the wholesale pertussis. Cost is also always an issue when it comes to vaccines, especially now that President Trump is cutting down aid to our part of the world. And so costs for those who have already started using it, like for instance, South Africa, Canada, they realize that all in all, the cost is much, much less compared to when they were giving the wholesale pertussis in terms of the logistics that it comes with this, in terms of the clinic visit that it comes with it. So cost has been duly studied, and they realized that cost effectiveness is much better with the acellular pertussis. So this is a summary paper for WHO that actually tells about us about the pertussis vaccine and the fact that the first dose should be given at 6 weeks, subsequently 4 to 8 weeks. And they actually advocate for doses to be given, especially with the pertussis, because remember, as I said, the protection that the vaccines give wane. And so with time, you need to give booster doses for protection. And so in summary, I would like to say that the acellular pertussis vaccine, it has a good safety profile. It is less reactogenic, and so you are less likely to have more adverse events following immunization. It has a high and persistent efficacy. And as I said, it's also cost effective. This lecture is just to stimulate us to think about it, to talk about it, because other countries are using it and we've seen the advantage of it. What about our children? If we want to bridge the gap, we need to talk about some of these other options that we have apart from what we are using here. So thank you very much for the opportunity.
Thank you very much, Dr. Asante. Can we put our hands together again for her? Very lucid and, thought-provoking presentation. Please, can you help me put? So my name is Obina Chukwudebe, and I'm actually a representative with Sanofi. I work as the immunization policy lead for Sanofi. And I want to say that I've also attended pediatric conferences in Nigeria, and coming to see what is going on here, I'm very, very impressed. Like, it's well organized, well put together, and a round of applause to all the organizers of this event. We're very proud to be associated with the Ghana Pediatric Association. So very quickly, just to introduce the vaccine in question, and then to further buttress what Dr. Asante has presented on the value of the acellular pertussis combination DPT vaccine in children, just to share a consensus statement by leading pediatric immunization experts across the globe. My slide changer is not working. Please, can you help me? Yes. Yes, can you help me, please? Maybe tap on the screen. Thank you. Okay, perfect. So some leading experts sat together this was published in October 2024 to talk on the impact of the acellular pertussis vaccine as compared to the wholesale pertussis vaccine on VCR globally. So they started by looking at the jeopardy on our VCR post-pandemic. We have the impact of COVID-19 on routine immunization is pretty clear on our healthcare systems. We have the compliance, timeliness of all the doses, country-level infant VCR, even though high in some settings, for example, like Ghana, communities with low VCR represent pockets of individuals susceptible to diseases, creating fertile ground for outbreaks. Now, moving on, we see the challenge of pertussis outbreaks still persists, as rightly stated and presented by our expert, Dr. Sante, and then the challenge of polio outbreak as well, the recurrence of circulating vaccine-derived polio virus in most of the setting, and all. And you can see that their summation in total was that the wholesale pertussis vaccine that is more often used in low-income countries is unfairly putting burden on lower-income families. And why is that so? Higher reactogenicity of wholesale pertussis vaccine poses the risk of lower acceptance and VCR, vaccine coverage rate, amongst poorer segments of the population. So this study was very, very clear, suggesting and posing that acellular pertussis hexavalent vaccines can help alleviate or elevate vaccine confidence and improve equity for the full birth cohort. So that brings me to, we can overemphasize the value of combination vaccines. Like someone would tell me, if we have 8 in 1, so that the child walks into a hospital, take one jab and protected against all the diseases, that would be fair enough. But today we are having 6 in 1 vaccine known as the Agsm. So just behind me here, the Agsm is the name of the product that Sanofi is providing to tackle these issues. It presents in prefilled syringe and in vial. You can see that the prefilled syringe even have 2 needles. So for the bigger baby, the smaller baby, we have it accommodated in there. It's pretty stable. Please, my slide changer. So this confers protection against 6 childhood killer diseases. It has the diphtheria toxoid, it has tetanus toxoid, the antigens, purified antigens from the Bordetella pertussis, the poliovirus vaccine inactivated injectable for the type 1, 2, 3, Haemophilus influenza type B, and then we have the hepatitis B, and all these 6 fully liquid in one syringe. You can see the sero protection, the seroconversion is persistent. Post-primary series vaccination after 2 or 3 doses, it is still very responsive, and post-booster is still very responsive as well in terms of the seroconversion level. You can also see the indication which I've listed, 6 diseases protected by just 1 jab. It can be co-administered with this, other vaccines, say PCV, MMR, rotavirus, even the meningitis vaccine, and co. All of them, we don't have any clinical relevant interference in the antibody response to each of the antigens as shown above. Now, you may ask me, where does it fit on our EPI? Now, you see it's 3 + 1, that is 6 to 14 weeks, and a booster between 15 to 18 months, as indicated on our calendar for all this. So I just wanted to share a quick, and then normal storage 2 to 8 degrees Celsius. So just a quick video to show that, we have time saved in the use of Agsm compared to our conventional penta vaccine in real life hospital practice. Please, can you click on this video or the operator? So if you can help me click on the screen, just about 30 seconds. Click on the screen. Okay. Sorry. As the video is coming up, please, I want to thank us all for, yes, exactly. Thank you so much. I want to thank us all for listening, and maybe we can take 1 or 2 questions while the video is being is being worked on to address both Dr. Asante's presentation and any question regarding this vaccine known as Agsm. Thank you very much for listening. So I don't know if we have any question. Please. So that means it's really clear and looks like we have the support of the Ghana Pediatric Association to fully advocate for a switch from wholesale pertussis combination DPT vaccine to the acellular pertussis vaccine to strengthen our vaccine coverage rate and then also to improve vaccine confidence and compliance in our practice. Thank you very much for that support.
Thank you very much for the presentation by Sanofi. Leading our panel discussion is Professor Catherine Sebethia. She is an associate professor of the pediatrics at the University of Ghana Medical School and a consultant pediatric hematologist and oncologist with a subspecialization in hemoglobinopathies, hemostasis, and thrombosis. Let's kindly invite Professor Catherine Sebethia.
Well, good afternoon, distinguished colleagues and guests. It's an honor to moderate this panel discussion today. Thank you so much to the local organizing committee for the opportunity. There's no doubt, as we have heard, that as a country, we've made progress. Clearly, where we are now is not where we were 20 or 30 years ago. The issue is not whether we have made progress. It is whether we are where we ought to be. Is Ghana where it wants to be in terms of child healthcare delivery? In 2025, far too many children in this country are still dying from preventable and avoidable causes. And it's not because we lack the knowledge to save them. There are people in this room who have been very, very well trained. However, for the Ghanaian child, healthcare is literally a fight for survival. No blood, no bed, no oxygen, no ambulance, no doctor, no medicine. Oh, I'm so sorry, your child didn't make it. For me, it is not a matter of resources, it is a matter of priorities. How do we ensure in this society that often, consistently, and constantly undervalues children? How do we ensure that every child, whether they come from a remote village in the Upper East region, or whether they live in a sprawling suburb in Accra, how do we ensure that they have access to healthcare that is their right? I'm looking forward to a stimulating discussion. Our panelists have diverse experience, and we're going to have a thought-provoking discussion on how we can reframe these challenges into opportunities for transformative action. I will now introduce the panel members. Their bios are in the brochure, and so in no particular order, I'd like to invite Dr. Edward Entry, who is the Program Manager for Newborn and Child Health in the Family Health Division of Ghana Health Service. Please take a seat on the stage. Dr. Salamatu Natoma, who is a Deputy Director for Information, Monitoring and Evaluation, also from the Ghana Health Service. Farm Genevieve Yaboa, who is the head Department of Pharmaceutics and Quality Control from the Center for Plant Medicine Research. If she's here, please join the other panelists on the stage. And finally, Dr. William Ansa Otu, who is a senior medical officer with the National Blood Service. So you're all welcome. Permit me to continue standing here. Everyone who knows me knows that I love to stand to talk. So I will stand here, and you have microphones, and you may need to pass them around when you're speaking. I'll just go through a few rules of engagement. Please keep your answers succinct. We only have 20 minutes. I will interject if I need to. Our focus today is on finding solutions. We're not here to cast blame. So we will not personalize the answers, and we will not engage in blame shifting. At this point, all of us are taking responsibility. So let's dive into the discussion. I'll begin with a broad question, and I will start with Dr. Salah. From where you sit, literally and figuratively, what do you think is the biggest gap in child health care delivery in Ghana today?
Thank you very much, and good afternoon to us all. I think that one of the biggest challenges we have is the disparity between the rural and urban when it comes to health workforce and also facility as well, which actually goes a long way to affect access to healthcare. By extension, we realize that at the end of the day, you probably may have a population in terms of, let's say, EMONG services that you expect that you should have at least in the population of 200,000, you should have 5 EMONG, that is including CMONG. You probably don't have enough to go around. And in the last harmonized health facility assessment, the other thing that came out very strongly was the fact that even though we said there was availability of the service at different levels of healthcare, there was a gap in the readiness to be able to deliver the service. So it's one thing saying that this level of care has this service package to be able to offer or to be able to do, but it's another thing whether they are ready or they are well equipped to be able to perform that function as well.
Thank you very much. And just running with the disparity between rural areas and urban areas, Dr. Entry, what does universal health coverage mean for a poor grandmother who can't even afford transportation to the nearest health facility?
Well, the challenge has to do with access and also, the ability to afford the service. But as UAC tells us, it's quality health service with access for everybody and also with no financial barriers. And in that regard, UAC is an aspiration. In Ghana, we've tried to work on the financial barriers by the use of the National Health Insurance Scheme to address issues of payments and so on. But we'll all admit that there are still challenges and gaps. Gaps in what the health insurance covers, and also issues about even people getting onto the health insurance scheme in the first place. So we do acknowledge that in spite of the aspiration towards the universal health coverage, we're still having the financial constraints, which impacts negatively on the health of our children.
Dr. Entry, I'm going to stay with you. I'm glad that you mentioned national health insurance. We know that this was meant to prevent catastrophic financial expenditure. It looks really good on paper. Unfortunately, as you said, it doesn't really work the way that it's supposed to. And if you engage NHIA, they will put the blame at the doorstep of the individual facilities and say that they have the policy and it's up to the facilities to implement them. I do not necessarily agree with that posture. I think we have a collective responsibility. So what can we do then? What bold reforms can occur? How do we get NHIA and facilities to sit at the same table so that we sort out this issue? Because at the end of the day, it is the Ghanaian child who suffers.
From where I work and where I sit, I would say that we need to engage health insurance, the health providers, and the Ministry of Health, which is more of the parents for the health sector. There needs to be engagement to see what the gaps are and what the realities are. And also for Ministry of Health to look to, get more funding into the health insurance scheme or system. Often you'd find health insurance on one side and the health providers also on the other side. But I think that we need to engage, talk about the issues, and collaboratively find solutions to what is confronting us.
You know, I agree with you. It's just so hard to get everybody to sit at the same table and to have that conversation. So now to Farm Yeboah. Many people will not initially go to a healthcare facility. So they may seek care from a traditional healer, or they may use some sort of traditional or alternative medicine before they go to a healthcare facility. And sometimes that delay is literally the thin line between life and death. How do you think that there can be better collaboration between orthodox healers and traditional or plant research healers?
Thank you for the question. So as you rightly said, because there's a bit of disparity in health facilities located in urban centers and rural areas, especially for rural areas, they resort to herbal medicine as their first line for healthcare delivery. And so a few things that we can do is, first of all, to start with research. A lot of concerns that have always been raised with herbal medicine is the efficacy of the medication, the safety of the medication, especially for children, the dose that's going to give the said efficacy. And so the first thing we should do to boost confidence in herbal medicine is to do a lot of research. And that's what we do at our center. And then apart from the research, we need to also develop appropriate dosage forms. We are talking about children who taste is a good factor for compliance to medicine. And so to look at better ways of delivering the herbal medicine, for example, looking at herbal extracts and converting them to dispersible tablets into suppositories, making sure that the bitterness of the herbs are sort of masked in the formulation. Another way we could look at it is also to engage the people from the traditional society and then train and talk to them as to what practices need to be bettered. I mean, we all do CPDs all the time to make sure that we are updated with the current methods by which we deliver health solutions. And so another way we can do that is to train them, make sure that whatever they are doing, whatever they are saying is the right way. And I think that way we can reach a lot of the populace with good health care.
So just as a follow-up, do any of those formulations currently exist for children?
So here in Ghana, the formulations that we have done at the center do not include children, because for children, after you've done the formulation, you need to do a bit of bioequivalence studies to look at how the drugs are eliminated from the system, how the drugs work. And we have not been able to do that. So we particularly focus on adults. But we are open to funding opportunities. Most of these things involve huge funding. And so we are open to funding opportunities to be able to have these equipments, expertise, training that allow us to formulate for children. Now, what we do is for adults. We look at solid dosage forms for adults. We look at rectal dosage forms for adults, where we convert the herbal medicine into the formulations. Another thing I think we can also do is to start looking at doing clinical trial for children with the formulations that we would come up with. And so I think that's what we can do for now. Get the funding and then start something.
All right. Thank you so much, Farmia Boa. From traditional medicine to blood, Dr. Ansautu. Blood shortage remains a critical issue. Our blood donation rate per population is very low. And it can take days to get life-saving blood products. Unfortunately, this has also created a thriving black market for blood products. I know that the National Blood Service is trying very hard. Some things have worked, others haven't. So what are some concrete steps based on what you know works? What are some concrete steps that the blood service is taking to ensure that we have enough blood to look after children who need to get those blood products?
Okay, thank you very much. Just to use the opportunity to thank my boss, Dr. Shelley Owusu. I think she was here, but she's left. There are several steps that the service has implemented as we speak. We must understand that as a country, we need about 340,000 units per year as part of our requirement of blood for us to be fine. But we've not gotten to that target yet. Education and awareness is ongoing. We still have the challenge with religion and cultural beliefs that tends to demotivate people from donating blood. There are a lot of blood drives that National Blood Service has undertaken, a lot of partnerships with organizations. With that fact, I think I would want to thank pediatric units for their collaborations with societies in organizing blood drives. I think they've been very helpful with that effect. We should appreciate them for that. We are also ensuring what we call National Blood Service visibility. As it stands, we have only 3 zonal centers. We have Northern, Central, and Southern zonal centers. Now, we have Central region and OT region, voter region, concentrating or putting pressure on our blood collections in the Greater Accra region, because the Southern zona is centered in the Greater Accra region. But what we are doing, which is still in progress, is to establish regional centers so that each region will be empowered, trained to collect their own blood and then meet the needs of their people. That would also reduce the burden on the zonal centers. We are aware of the fact that there are blood cartels that are in the system. And I think from our end, we must understand that blood is available is not enough. The blood must be safe. If the blood is not safe, you cannot transfuse. And so we as a service have put certain systems in place in terms of safety. There's an act, but we are still trying to work on the regulations where these blood cartels could be penalized should they be, arrested. The challenge we have here, and I must say, is that most of the times we've had people brought into the police station either because they were holding bad blood or they were exchanging, money with someone else. And what happens is that when we need a witness to come in to attest or even an evidence to that effect, they shy away from that. And that has been the challenge. So we cannot even proceed to the next step. We would want to encourage all of us to, just talk to their patient relatives to be aware of that. I don't want to talk a lot. The last thing I would want to say is that at the hospital level, we also have a responsibility to play. If you're a clinician, and you told the patient relative to get a unit of blood, and the blood arrives, the first thing is that you must know the source of the blood. Most of the time they will tell you it's from 37, it's from Rage, it's from Kolebu, but you must confirm the source. Number two, you must look out for certain DIN numbers, the label, make sure the blood looks a bit viable before you now proceed to the next step, which is to return the blood to the blood center or the blood bank for array testing, regrouping, and compatibility testing before you now proceed to transfusing the child with the blood. This is very key. It's important because mostly we have these cartels. In fact, some even bleed. They have, they bleed in their rooms. They've printed labels. They put it on the labels and then they bring it out. So please, let's also ensure that we are getting safe blood in our system. Thank you.
Thank you very much. I'm just going to pick up on what you said about cultural misconceptions and ask Dr. Salah. Let's talk about fake news and how that can undo years of planning and implementation and trying to ensure that you are giving information that is correct to the public. How does fake news interfere with the goal of this conference, which is universal health coverage?
Yes, so to a large extent, what's the information that goes across to the community or to the public determines how they interact with the health service or whatever service that we want to provide. And it can either make them accept what we are giving to them or refuse what we are giving to them. And I think a clear example was even what happened during COVID when we had a lot of vaccine hesitancy. And that was because of misinformation and how information was carried across. So I think that it is one of the aspects that we really have, that is very critical, that we have to own as a health service. To a large extent, sometimes we leave that aspect of healthcare delivery to either people who are not well trained to do it because we feel that you probably are too busy to spend time to do the education, or we leave it just for people to guess. So I think it's an area that we really need to own and determine what goes out there in terms of every health information that we want to carry across. And we also have to take advantage of the new modes of communication and how people want to hear information and where they want to hear it. We should take advantage of it and ensure that that is where we also transmit our healthcare information.
Thank you so much. So we've heard about the problems with NHIS. We've heard about the importance of health information. We've talked about how research can promote the theme of this conference. Some of the problems around blood availability have been highlighted and the steps that the National Blood Service is taking to try and overcome these problems. We only have a few minutes left. And so the final question goes to all of you. So you'll take turns to answer this. So whoever has the microphone can start and then you pass it on. If you were the president of Ghana for one day, and that day is today, the 7th of February, 2025, and you could implement one bold, game-changing policy or initiative to accelerate universal health coverage for children in Ghana, what would that one policy be? So Dr. Salah, you have the microphone, so you can begin.
Okay, so I think I also have a bias towards networks of practice, which is the selected means that we are using to drive the achievement of universal health coverage. And the reason is that I think that it is the one policy that calls all of us to work together in teams to ensure that we are able to expand access, because it is obvious that there are certain times that you may not be able to get critical staff to every place within the country, but we can use the working in networks and also take advantage of telemedicine to ensure that if one person is in one side of the country or is in one side of the community, the person still gets to have the advantage of getting the inputs of that specialist in the district hospital or in the tertiary hospital to ensure that they get the right quality of care. And it also enhances the referral process, which is a very big gap that we have in our healthcare delivery system, being able to define clear referral pathways so that it is easier to move patients from one level of care to the other when it comes to children.
Thank you, Dr. Salah. Dr. Intri?
I would look at the issue of equipment and supplies. The human resource is important. We need to get people in the right numbers at the various centers. But we also have issues with equipment and supplies, and that needs to be looked at and tackled head on. Thank you.
Thank you. Yeboah?
So I'll be also biased towards what we do. And if I were a president, my policies will focus on investing heavily in research and development. Most of the medicines that we always get for pediatrics are medicines that the research and development happened outside, and then we just follow when the patency is gone and then we formulate. But what about we getting orthodox medications by isolating from plants, producing them heavily ourselves here to make sure that medicines are affordable and accessible to our own country? You never know when the supplies you are going to get is going to stop. And so if we are able to heavily invest in research and development here and also help local industries, manufacturing industries to produce as many medicines for pediatrics as possible, then we can cut down on costs and make sure that medicines or healthcare delivery to children are very good.
Thank you so much, Dr. Ansel. So you get the last word.
Thank you. It quickly came to mind that the anti-LGBTQ plus bill must be passed if I was the president. But then I remembered I'm from the National Blood Service, so I need to concentrate. Yes, so as a president, what I would make sure is done is establishing regional centers for blood donation. If you have enough blood in the system, commercial donors would reduce. You wouldn't have these cartels around. So I think that's the one thing I would do.
From your lips to President Mahama's ears, I'd like to thank our panelists. We know that prioritizing children's health is a national imperative. Who holds the system accountable when a child dies from a preventable cause? Let us move beyond discussions and commit to real action. It's time for us to put our mouths where our money is. Thank you all very much.
Thank you, panel members, for the stimulating discussion. We have a representative from WHO here who will be tying in all this discussion. She's in the person of Ajua Chimwa Amponsa. If she's here, please kindly make your way to the podium.
Good afternoon, everyone. Chairman, permit me to stand on existing protocols. I must say that I was really delighted when I was asked by the officer in charge of WHO, Dr. Frank Lule, who could not be here because he had other engagements, which has taken him out of the jurisdiction altogether. Because I must say I am a disappointed pediatrician. And so when he said, you should go and represent me, I said, talk no more, this is home. And I can see some of my senior colleagues, I worked under them at the Children's Hospital, Aflata, all here, and my teachers all here. And I must say that it's more than a delight to actually share a few thoughts on UHC. So what is UHC? UHC ensures that all individuals and communities receive the health services they need without suffering financial hardship. In Ghana, the vision for UHC is quite clear. All people in Ghana must have timely access to high quality health services, irrespective of their ability to pay at the point of use. This vision aligns with the Sustainable Development Goals and the Global Action Plan for Healthy Lives and Well-being for All. Despite our significant progress over the years, challenges remain in child healthcare delivery in Ghana, as enumerated by our panelists not too long ago. The Ghana Demographic and Health Survey Report of 2022 shares these statistics. Neonatal mortality rate, 17 deaths per 1,000 live births. Infant mortality rate, 28 deaths per 1,000 live births. And under 5 mortality rate was 40 deaths per 1,000 live births. The primary causes of child mortality, such as malaria, pneumonia, diarrhea, and malnutrition, are preventable and treatable with simple, low-cost interventions. However, disparities in access to these interventions persist, particularly in rural and underserved areas, and for those with low socioeconomic status. To address these challenges, we must adopt a health system approach that focuses on strengthening the entire healthcare system in child healthcare delivery in Ghana. Primary healthcare, I agree with our colleague from Ghana Health Service, is the cornerstone of UHC. By investing in PHC, which is a primary healthcare, we can ensure that essential health services are available and accessible to all children, regardless of location and economic status. Strengthening primary healthcare includes providing infrastructure, increasing the availability of medical supplies, and training healthcare workers. The Network of Practice initiative, which is one of Ghana's flagship strategies to attain UHC, focuses on primary healthcare. Network of Practice leverages technology to create a linkage of primary healthcare facilities within a defined geographical area to provide comprehensive health services. We need to collaborate and strengthen our NOPs by ensuring availability of all essential medications and commodities for childcare, presence of motivated and trained staff in all our church compounds, as well as equipped hubs. A resilient health system relies on a well-trained and motivated workforce. Investing in the education and training of healthcare workers at the primary care level, particularly in the management of common childhood illnesses, is therefore paramount. WHO supported the Ghana Health Service in designing a hybrid capacity building program for health workers at the district level in the integrated management of neonatal and childhood illnesses. This program, which is an online learning session, is currently available on the WHO Academy platform. Engaging communities in healthcare delivery is essential for building trust and ensuring that services meet the needs of the population. Community health workers therefore play a vital role in delivering care at the grassroots levels, providing education and promoting healthcare behaviors. Another key issue when it comes to sustainable or achieving UHC will be health financing. The government of Ghana has identified financial sustainability as a national priority. The National Health Insurance Scheme covers majority of childhood illnesses and has since June 2022 added treatment of the 4 common childhood cancers to the National Health Insurance Scheme benefit package. There is avenue for national health insurance to continually increase its coverage and also ensure that the tariffs they generate are not only ensuring efficiency gains, but reasonably priced so that we can meet the economic demands of the healthcare system. We therefore need to strive to eliminate out-of-pocket payments for some medications, oxygen, and other essentials to make the free healthcare for children under 5 100% free. By leveraging domestic resources and strategically utilizing international support, we can ensure that healthcare services for children are adequately funded. Robust data and information systems are necessary for research, monitoring and evaluating healthcare delivery. The District Health Information Management System, which has been operational since 2012 and is available in all health districts in Ghana, is a comprehensive health information system for capturing, reporting, and analyzing health data for the healthcare ecosystem in Ghana. Improving factors like internet access, availability of functional ICTs, frequency of supervisory visits, and staff training may facilitate the use of DIMS in collecting and analyzing the data on health outcomes of children, identifying gaps, tracking process, and making informed decisions to improve child healthcare services. Integrated health service delivery with other sectors, such as nutrition, water, sanitation and hygiene, and education, is important for addressing the underlying determinants of health. This holistic approach ensures that children receive comprehensive care that addresses their physical, mental, and social well-being. Building resilience in child healthcare delivery also involves preparing for and responding to emergencies, such as disease outbreaks and natural disasters. This requires strengthening the capacity of health systems to withstand shocks and continue providing essential services. Developing and implementing emergency preparedness plans ensures that health systems can respond quickly and effectively to crisis. This includes training healthcare workers, stockpiling essential supplies, and ensuring that our ambulance services are free, accessible, and well-equipped to handle a pediatric emergency. Partnership with developing partners, NGOs, and the private sector is vital for building a resilient health system. By working together, we can pool resources, share expertise, and implement innovative solutions to improve child healthcare delivery. In conclusion, achieving UAC and building resilience in child healthcare delivery across Ghana requires a comprehensive and coordinated effort. By adopting a health systems approach, we can identify and address the gaps in healthcare delivery, ensuring that all children have access to high-quality services and build a resilient health service that can withstand future challenges. WHO remains committed to continue its collaborations with all key stakeholders in achieving a resilient healthcare delivery system for all children in Ghana. Let us work together, leveraging our collective strengths and taking bold actions to ensure that every child in Ghana can thrive and reach their full potential. On this note, I congratulate the Pediatric Society of Ghana on an excellent organization of this annual general and scientific conference. Thank you all very much for your attention.
Thank you. Thank you very much, Ajua. A short message from Novartis right before we move into our next panel discussion.
Good afternoon, everyone. My name is Dr. Ashray Naik. I am the Associate Director for Global Medical Affairs in the Novartis Malaria Program. As you can guess, I have come from India. But in the last few days, I've been going around in Ghana, meeting people, and all of you have been so friendly and welcoming that I feel at home here. So thank you so much. I'm also the odd one out at this conference because I'm a gynecologist by training. But I'm here to advocate for the young infants who are less than 5 kg of weight, who do not have a tailored formulation of an anti-malarial available anywhere in this world. So to address this unmet need, Novartis has developed a dose optimized formulation for young infants less than 5 kilograms of weight of artemether and lumefantrine in the ratio of 1:12. We have also done a phase 3 trial called Kalina to verify the efficacy, safety, and the pharmacokinetics. So today, I'd like to start with a short video from our global clinical head, Dr. Preetam Gandhi, who will take us through the Kalina presentation in the next 5 to 10 minutes, and then we can open the floor for questions. So I would request my colleague Bafi to please play the video. Thank you.
Afternoon. I welcome you all to this session where we are reporting primary results from phase 2 Kalina study. All of us might have been involved in studies, malaria studies especially, which have been done in patients more than 5 kg. We all know that pediatric population is the target population. But I'm especially pleased to share results of this study. Because we are targeting neglected population. For years, there have been no evidence collected or very limited evidence collected for patients less than 5 kg. And here we have done a phase 2-3 study to collect PK, safety, and efficacy information of a revised dose for patients suffering from uncomplicated pulse.
Hello. Apologies for the technical glitch whilst we work on the video. We will give you a short break and then we'll go into our next panel discussion. Then afterwards, we get the video. So we work on the video and invite Novartis up again to complete their presentation. We'll go into the next panel discussion being led by Professor Anthony Enemel. He is the head of unit at the infectious disease at Akomfanochi Teaching Hospital. A round of applause for him.
Good afternoon, everyone. I'm also standing on all existing protocols, including the one that my previous moderator laid down. So I don't need to start everything all over again. I would introduce my 5-member panelists through step by step. I'll just give a brief scenario and then put them in the right perspective as they come. So there's a highly mined Galamsey area called Wasa Japa. Actually, you see mining by the roadside. It's overmined. There's an 18-year-old lady called Joyce, who the popular name they call her is she's a service provider. She provides all sorts of services to the Galamseyers. So she got pregnant and then delivered a preterm. The child couldn't act or move. So had to be put in what we call tricycle, Abubuya, to the nearest facility instead of an ambulance. And I'm going to call on Dr. Felicia Freeman. Please, let's welcome her. before she starts answering her question, why Aboboya instead of ambulance? So think about it. We are not talking about University of Ghana Medical Center or Accra. So as you go, just think about how to respond to that question. So that's your chair. So they got the child to a small village. It's not a small village. It's called Wase Kropong Hospital. The child wasn't breathing. So how do you kickstart the heart, or how do you resuscitate the child? You need some medications, and you need a clinician. There was actually a PE on duty. So I'm just going to call on our clinician, Dr. Nicholas Ashiade. Please join us. Let's clap for him. I've given you a preamble. What do you do in that district hospital when there's nothing, as compared to University of Ghana Medical Center, where all the experts are? So that's my reference, University of Ghana Medical Center and Wase Kropong, where there's nothing. And then I'll call on the pharmaceuticals representative here, Dr. Nana Abuaji Asari. Let's welcome her. Yes. I know you just came in, but tell me the medications, how it will be made available to the child in Wase Kropong. And then this child grows up and had to be named. Remember, Ghanaians, we are highly religious, so there's always a naming ceremony. And then as you go to school, of course, marriage and all that. So then there's a reverend minister. What role does the churches play or Christian council play in shaping the future of the Ghanaian child? So we will call on the Christian Council of Ghana, Reverend Johaida Godwin Amuzu. Reverend Amuzu. Thank you. And the last but not the least, we need to educate the Ghanaian child. Children must go to school. This young boy who got asphyxiated, had to go to school. He's also a Ghanaian. What arrangement do we have for the Ghanaian child in terms of education? So I'll call on my last panelist member by name of Miss Evelyn Kumiwa Opong. Please, let's welcome her. Where is she? Yeah. So, to welcome our panelists, and I know you are thinking about how to respond to my question. My main questions are coming up, and I'll start with the clinician. How can clinicians ensure that quality healthcare is accessible? Looking at the scenario I gave, how can we ensure that it's accessible for every child, regardless of whether they are born to Joyce, who is a service provider to the mining community? And it's every service provision. That's how she became pregnant. How, despite the socioeconomic background, how can this child be supported if they find themselves in Wasa Japa? Thank you.
Thank you very much for the question. Good afternoon, everyone. Yes, so as a clinician, for you to be able to ensure universal health coverage, I think it starts with you having knowledge of essential health services, because then that's the main pillar of primary health care. And these essential health services would include things having to do with health promotion, prevention, treatment, rehabilitation, and then also palliative care. Now, the reason why it's important to have this knowledge is so that you can tailor services within the context of limited resources you have in order to meet the needs of the community that you serve. Now, understanding essential services, not only in the broader term, but also as it applies to the community in which you find yourself. And so what may be needed in one community may not be the situation in, for example, a mining community as the scenario was painted. So having an understanding of this is key. Then again, you should also understand the socioeconomic profile of the communities that you're working in. What are the main occupations? what is the average income per household, who is the main breadwinner, and all of that. Now, when you understand these things, then you can plan your health services. For example, in receiving this child from a mining community, if you have been involved in health promotion and preventive practices, you will understand that there are peculiar conditions that have to do with newborns coming from such mining communities. I'm sure we are all aware of the Galamsey menace and all the problems.
If you could run up your, I'll come back to you later with more details. So.
Very well. So yes, essentially, understand the essential services as they apply to your community, understand the socioeconomic profile, then you can plan your health services and tailor them to meet the needs of the community.
Thank you very much. So I'll go on to pharmacy services. How can pharmacies ensure that essential medications, this child needed to be resuscitated, but there was nothing there. Health supplies are available and affordable for children who are even born to, in quotes, service providers, in the sense that I gave.
Okay, so thank you very much, and greetings from the Pharmaceutical Society of Ghana. Pharmacists can ensure that these essential medicines are available basically in three ways. The first being the fact that if we do enhance as a country our local manufacturing, ensure that there's a presence of local manufacturing and actually have capacity to get those medicines. The previous speakers talked about importation, which is a problem. If we are able to ensure and enhance our local manufacturing, that's one way. The second way is also to ensure that, in the various spheres or the various cadres of the Ghana Health Service system, the various community pharmacies that are designated as private are actually inculcated into the primary healthcare scheme of things. So whether it's district, municipal, metropolitan, or whichever area it is, the community pharmacy, the OTCM that is there is also integrated such that there can actually be a link between the service, the hospital service provider, and then the pharmacy service provider. As pharmacists, another thing that we also do is to get some global funding. Currently, we do have a project we are running with Ghana Health Service in the Upper West and Upper East, which is on maternal and neonatal health, to ensure that essential medicines are given to reduce that. Those are the areas that pharmacists can help.
Yeah, I'll be coming back to you.
Yes.
Now, this child's first transportation was in tricycle, Aboboya. If this child had been in Accra and was to be transported to University of Ghana Medical Center, I don't think it would have been Aboboya. It would have been ambulance, first class ambulance, or taxi. Yeah, so I just want your input on how can we make sure there's universal access for every child, irrespective of where you are born, the best in terms of transporting a child to health.
Thank you very much. So obviously, Aboboya is the wrong mode of transport for injured or ill patients, especially the pediatric patients. Now, there are a lot of gaps that we have to address to be able to make universal health coverage possible for all pediatric patients. One of these gaps, the major challenges that we have is a finance mechanism. The National Ambulance Service does not have its own independent finance mechanism. We depend on the government for funds. And as a result, it makes, financial restriction an issue where you have ambulances that are out of commission because they have to be repaired, or even maintenance of these ambulances. It becomes a problem. So because of that, you have decreased number of ambulances to dispatch for emergencies. Another issue has to do with the perception of the public. And in this case, I want to use a scenario. So some people actually think that ambulances are used to transport diseased individuals. So they are not willing to enter an ambulance. And even though we have been educating the public and it's ongoing, they still have that perception. So they don't wish to even know the number to even call or to even know how to even access an ambulance. The other thing is they also feel it will delay response time, because going to call the ambulance control for them to dispatch an ambulance to the emergency scene, they think it will take so much time. So they'll prefer picking the aboboya and then transporting the patient there.
Yes, we'll come back to you for the way forward, since you still need to get money from the government. We'll hear your innovative ways to generate, but there are a few instances where ambulance were carrying yam. So I'll go to the Reverend Minister. How are churches contributing to awareness and support for universal healthcare initiatives in our communities? Reverend Amuzu.
Thank you, Prof. Anthony. It will interest you to know that the church, and for us at the Christian Council of Ghana, we have the Christian Health Association of Ghana. It's an association of 34 Christian denominations. We have contributed to the establishment of healthcare facilities across the country. Currently, we have 374 healthcare facilities scattered across the country. Through these facilities, we support the state to extend the needed healthcare to our children and to the rest of our people. The health personnel in our churches always are at the service of our people during special occasions. We make good use of them. We do health screening. We do advocacy. That is part of the core values of the PSG. We do a lot of advocacy. We do a lot of networking and partnership, so that collaborating with key stakeholders, we ensure that the right things are done for our children, not only those in our churches, but those in the communities where our churches have presence. Issues about ambulance and all that, once these things come to our attention, we ensure that we raise our voice. We use our presence as the voice of the voiceless in society, so that what some of these state institutions cannot do, because of our stature, we are able to talk to the people in authority.
Okay, Reverend, I'll come back to you. You are actually giving me solutions. I'll come to the solutions in the second round. So Evelyn is the last but not the least. We are all here because of good education that we have had. Evelyn, let's hear from you. How is education system leveraging to promote health education and preventive care among school-going children?
Thank you very much. Ghana Education Service has incorporated health education in our curricula and co-curricula. So we have school health education units from the headquarters to the regions through all the districts in Ghana. And the school health education units also train teachers who are still in the classroom, but specially trained so that they can help our children when it comes to health awareness education. So anytime there's any health alert or health issue, we get in touch, or the Ghana Health Service gets in touch with Ghana Education Service, and we educate the children from hand hygiene, personal hygiene, environmental hygiene, nutrition, all aspects of health issue, so that the children will know that when I touch services, I pick up germs. So proper hand washing is the best. And formerly, we used to have a lot of protocols in getting nurses to educate our children in schools. But long protocol has reduced. So we have schools assigned to health facilities closer to the schools, that in case of any health issue, we quickly get in touch with them for them to come to the school, or if it's any minor issue, the trained school-based health coordinators do that education on behalf of the health officers.
Yeah, thanks very much. I wanted to have followed up with another question, but on a second thought, that would have been political. So, but the society is apolitical, so I wouldn't go there. Can we come back to, yes, clinician? Because of time, I would just allow you. Can you mention some barriers and then add on how can healthcare providers work with community health workers to improve preventive care and early detection of diseases in children? I've combined two so that we can finish early. Thank you.
Very well. Thank you. So for someone who has worked in the district for a while, one of the major barriers to provision of care is the lack of essential equipment and sometimes even inadequacy of essential medicines. Now, when we talk about equipment, we are not necessarily talking about the big stuff. We are not talking about the incubators and everything, but things as basic as three-way taps, a lack or inadequacy of oxygen, and some of these basic things. For example, even CPAP, for most of my practice in the districts, we've had to improvise for something like the CPAP, for example. So this is a major challenge. The other key challenge I would mention is the fact that our patients have to source or fund from their own pockets some of the services. For example, without blaming anybody, ambulance services, for example, it is still happening in the districts that when you need to transport a patient to a referral center, one of the key things that would come up is who pays for the cost of transportation. And oftentimes it's transmitted down to the patients to cater for. Now, how can we work with those in the communities? For any clinician working in a community, like I said before, understand the community you are in, then you can be effective. So for then your community health workers who are in the field, every now and then you have to provide support. Sometimes you have to be there in person, helping them to identify high-risk cases or patients and then advising them on what to do. Indeed, this also provides like a learning or teaching opportunity for those in the field. Thereafter, it's essential to identify and establish channels of communication with key stakeholders. For example, you're working in a district hospital and then you don't have a channel of communication with your district director of health services, you're not going to be effective. Oftentimes, you have health centers around you. So once that communication channel is there, sometimes you may not even have to go there. You can leverage on teleconsultation and advise those in the field on what to do. With these things, I'm sure that we can pick up and actually address sometimes in the field problems, which would have been brought to you in the hospital setting to deal with. So I think these few things can improve work with our community health workers.
Thank you. Can you give it to Dr. Freeman? Yeah, so I'll come to you before I go to the pharmacist. So we're talking about getting mobile ambulances for every part. I just want to suggest, and then you give me your comment on my suggestion, and you give me alternatives. Now, within the mining community, the tricycles called Aboboya, they are like pure water. In fact, I think when I spoke to one of them, they invest a lot in the tricycle. That's what they use to cut their sand, to wash it, and then do their extractions. Can we be innovative and convert some of the ones they are used to into a mini ambulance, such that we equip it, because they like that than waiting for ambulance to come from Tapa. That would be the nearest point, so that it can be repurposed and then used for that purpose to transport when we equip it. That is what I have observed, but I want yours, and also comment on mine if it's feasible. Thank you.
Yes, so it's possible. It's one of the projects that's on our CEO's table to see if we can have more like a mini ambulance, as you put it, in those areas, because accessibility to those areas is also a problem. And at least having this, in quotes, tricycle, but well designed with monitors and other things will help in movement or transport of these, of the patients. And in addition, we'll have skilled EMTs as well. So it is one thing that we are looking at, and we hope it will be something that we'll be able to have soon in our country.
I thought you were adding more.
No, that's it.
That's
Yes.
fine.
You want me to add on?
No, because of time. Okay, so let's hear from our pharmacists. How can pharmacists collaborate with other health providers to improve overall healthcare delivery system for the Ghanaian child?
So the first thing I say is the fact that in our training as clinicians, as pharmacists, as health professionals, there are certain courses that we do together, or we do individually. We do it in silos, but primarily it's the same thing that is kind of taught throughout. One of the ways that we can incorporate teamwork and that interdisciplinary team build is to try and see if right from training, we can actually have that interdisciplinary education with the various health professionals that are taught the same program. The second thing that pharmacists can do in all of this, as said earlier, is to be part of the primary health care system, which currently we are not, because we are seen purely as a private entity. So if we are able to integrate that into the network of practice, which is key for the Ghana Health Service, that is another way that we can ensure that there's that team build, and then you know what is happening on the community pharmacy front, and then as well as in the hospitals. The third thing is perhaps the fact that there should also be employment of pharmacists across the various hospitals, across the various levels of health service delivery that we have in Ghana to ensure that there is pharmaceutical care where it is needed. Thank you.
Thank you very much. Let's go to Reverend. And just let me say before I forget, everybody here, you're in a position to advocate for Pediatric Society. So don't let this discussion end here, but take it beyond to your superiors, to your bosses. And now that I know the First Lady is our partner, ultimately to the First Lady, and it will get to the President by the next meal. Thank you very much. So, Reverend Amuzu, what role does the clergy play in promoting preventive healthcare practices among children and families? I know you mentioned some of the roles, but is there any other additional information you can give us targeting children, women, and families? Thank you.
Yes, one of the major areas is access to preventive health care. We know that many of our healthcare professionals would like to live in comfortable areas. So as part of our advocacy, we ensure that we send our health facilities to the remotest places and collaborate with stakeholders to ensure that social amenities are provided, in those communities to encourage health professionals to go there. We use the pulpit to admonish our families to take exercising, very important, because prevention is better than cure. And in addition to the advocacy, we practically organize health walks. Occasionally, our youth providing leadership to make sure that our children, our families are healthy. We preach chastity. We know that one of the greatest threats is sexually transmitted diseases. And even children 12, 13 can be exposed to the dangers of premarital sex, and all those things. So we advocate chastity. It's very difficult nowadays for our young people and even children to stay away from those because of the proliferation of social media. But we are doing our best to ensure that messages on chastity are reinforced so that our young people will stay away from sexually transmitted diseases. As the second largest provider of healthcare services in the country, we want to continue our collaboration with the state to ensure that our healthcare professionals are adequately compensated so that they can continue to serve our nation. You heard the other day how some heads of state institutions, how their emoluments are, their compensation. I mean, it's so mind-boggling. Now that we are getting to know these things, we will strike so that some of these resources can be channeled to support our healthcare professionals so that they can take care of our health. Thank you.
Thank you. So let's go to our sister Evelyn. The best is always reserved for the last. So that's how come I'm making you the last. So in what ways can schools play a role in identifying and addressing health disparities among students? In what ways can schools, Ghana Education Service, play a role in identifying and addressing health disparities among students?
Thank you. Because of the health education system we have in our schools, we normally have health screenings. And this is difficult in certain areas, I must confess, especially Greater Accra, because we are, I think, the heart of the nation. So things are easier when it comes to healthcare in Greater Accra. But when you go to other regions or other districts, which are really not the city of that region, it's very difficult. Now we are trying to close that gap with health education. We have intensified. So every corner you go, we liaise with the health officers there to go into the schools to have education. Our normal Wednesday worship days are not solely for church service now these days. It's basically on health education. And I think children are agents of change. So whatever positive you tell them, they also take it home. We have also involved the PTAs now that any health issue that rises, we meet the parents and we address the issue. So I think that is helping us to bridge that gap and that disparity between healthcare.
Shall we give them a round of applause? Yeah. In the interest of time, we need to end here. Let me acknowledge the availability from Christian Council of Ghana, Reverend Johaida Godwin Amuzu. And I know he talks to the Muslim Council, Pentecostal Council. So send our message to them as well. They also are a big party. There are children in all their schools. Let's make sure we keep the information going. And then our clinician here, Dr. Nicholas Ashiadi, again, you are part of a bigger group, Ghana Medical Association. Let's get the message across to a parent, go to Pharmacy Society, Dr. Nana Abuaji Asare. The point we are making is let it go beyond our interaction, get it to the leadership, and let's see it can come to one change. We are going to the ambulance services, as we've said, there are big challenges, but let's be innovative. Let's look at low-hanging opportunities and what is applicable in which community. Let's do something different that will work. And finally, but not the least, from Ghana Education Service, Miss Evelyn Opong, please send a message to the new Minister of Education, Haruna Idrisu. Tell him he should remember the child because he was once a child. On that note, thank you very much. Thanks for the opportunity to serve.
Thank you very much, panel members. Novartis will complete their presentation. We'll be going for lunch soon, I promise. I know we are all hungry. In the interim, after Novartis' presentation, so that as a reminder, if you have any questions on Agsm, Sanofi is back there. The rep will be more than happy to engage us and discuss further. Thank you.
Hi, I'm back without without wasting any more time. I would request my colleague to please play the video, and I hope it works this time.
All to the session where we are reporting primary results from phase 2-3 Kalina study. All of us might have been involved in studies, malaria studies especially, which have been done in patients more than 5 kg. We all know that pediatric population is the target population. But I'm especially pleased to share results of this study because we are targeting a neglected population. For years, there have been no evidence collected or very limited evidence collected for patients less than 5 kg. And here we have done a phase 2-3 study to collect PK, safety, and efficacy information of a revised dose formulation or optimized dose for patients suffering from uncomplicated falciparum malaria less than 5 kg body weight. So let me take you through background. As I said, there are many antimalarials available for patients more than 5 kg, but there is hardly any evidence or systematic evidence collected for efficacy, safety, or PK for patients less than 5 kg. What's the result of it? That these patients, they continue to be treated off-label with same doses that are meant for patients more than 5 kg. And that have efficacy as well as safety concerns, that could have efficacy and safety concerns for these young babies. We also tried conventional disposable tablet of 20 milligram, 120 milligram artemether lumefantrine, which was approved for more than 5 kg. We tried it to evaluate it in patients less than 5 kg, but it resulted in elevated exposures of artemether, exposures which have been found to be associated with neurotoxicity in preclinical studies. So that forced us to stop, think back, and revise the dosing for patients less than 5 kg. We went back to the table, we did a PBPK modeling to identify what should be the right ratio of artemether lumefantrine for these young babies. And we came to a conclusion that maybe if we start from a ratio of 1:12 instead of 1:6, we might be able to achieve right exposure without compromising exposure for lumefantrine. So therefore, we developed a new dose strength of 2.5 milligram, 30 milligram of dispersible tablet and started a phase 2-3 study called Kalina, that is artemether lumefantrine in infants and neonates suffering from acute malaria. This is a multi-center open-label single-arm study which was done in Burkina Faso and DRC across 3 centers. And the primary endpoint for this study was PK, to check artemether and lumefantrine exposure, and also then secondary measures were efficacy and safety. This was a sequential age descending study design where we started with infants more than 28 days but less than 5 kg in cohort 1, and we continued into infants or neonates which were less than 5 kg in cohort 2. We followed them up to day 43, including 3 days of hospitalization at the start. And then we also had a long-term follow-up for day 44 to the first birthday to check the neurodevelopmental status. And these data which were collected from the current study, they have been supplemented with the PBPK modeling and simulation. Which patients were included in the study? Both males and females infants, male or female infants, and neonates, which are less than 5 kg but more than 2 kg. So premature neonates were not included in the study. Who have microscopically confirmed diagnosis of Plasmodium falciparum with asexual parasites more than 500 in cohort 1, more than 100 in cohort 2. But patients who are malnourished, microcephaly, severe malaria, hemoglobin less than 7 or HIV status were excluded from the study. As I said, primary endpoint for PK endpoint, as is expected in this vulnerable population, also suggested by various health authority guidelines and research guidelines, that wherever possible in vulnerable population, we should try to bridge the data from the efficacy and safety and exposure consent exposure data what we have from older population. So we try to do that by assessing PK Artemether Cmax as primary endpoint, lumefantrine day 8 concentration as key secondary endpoint. Now we all know lumefantrine day 8 concentration is a well accepted marker for efficacy, cure rate. Other endpoints were safety and tolerability, of course, and we also checked cure rate, PCR corrected and uncorrected, and parasite clearance time. So the kind of patients what we included were representative of the general malaria infected population. We had 22 patients in cohort 1, 6 in cohort 2. All of them completed follow-up up to day 29. All of them completed 1 year follow-up also, except one in cohort 1 who was lost to follow-up. Median age was 96 in cohort 1 and 22, and you'll be surprised that we even got one patient on the day of his birth. Median body weight ranged from 2.8 or the body weight ranged from 2.8 kg in cohort 2, the youngest, the lightest baby, to 4.98 in cohort 1. Both males and females were represented in the study. Median parasite count was 8,000 approximately in cohort 1 and about 3,600 in cohort 2. They'll be surprised that the maximum parasite count what we saw in these babies was 156,000. So it kinds of breaks the notion that these patients less than 5 kg, they do not suffer from malaria. Now coming to the results, the primary endpoint which we wanted to check was Artemether Cmax, as I said, and we wanted to compare it with the historical data. The historical data where we looked at exposures observed in 5 to 15 kg with dispersible tablet 20 milligram, 120 milligram, and that was reported in 2008 in Abdullah's study. Now, as you can see on this chart, that both in cohort 1 and cohort 2, Artemether Cmax falls within the range of what was observed and proven as efficacious and safe in patients more than 5 to 15 or patients 5 to 15 kg. So cohort 1 met the primary endpoint which was considered to be met if the 90% confidence interval of Artemether Cmax contained the target value of 101 nanogram per ml that was derived from Abdullah 2008 study. So you can see that cohort 1 geometric mean was 68 with 90% confidence interval of 45 to 103, and hence it met the primary endpoint. Cohort 2 sample size was inadequate for a conclusive analysis. However, the 90% confidence interval did contain the target range which we had set out for the study. Same is the story with lumefantrine day 7 concentration. Cohort 1 met the primary endpoint of having upper limit of 90% confidence interval more than 212 nanogram, and cohort 2 sample size was inadequate, but still the upper limit was above the target of 212 nanogram. And you can see on the chart the concentration are within the range of what has been observed to be effective in older population. Now, did this PK concentration reflected in efficacy? Yes. So as I said, that lumefantrine day 7 concentration we all know is an accepted marker for efficacy, and we looked at PCR corrected cure rate, and you could see that both in cohort 1 and cohort 2 corrected cure rate was above 95%, and which is comparable to what has been observed 97% in Abdullah 2008. Now a PCR corrected cure rate of above 95% again is a well accepted standard efficacy marker for any new antimalarial. About parasite clearance or the speed of action, again parasite clearance observed in the study, median parasite clearance was 35 for cohort 1, 30 for cohort 2, and it is consistent with 34 hours that has been observed in Abdullah 2008 with patients 5 to 15 kg. So overall, not just the PK, but the PK results were reflected in a good efficacy also in the study in the target population. And now let's talk about safety. The overall safety profile of this optimized dose in the study was completely consistent with what we have observed in patients weighing more than 5 kg historically. There were no new adverse events. There was no death, no SAE, no treatment discontinuation due to adverse events that were observed. And not just this, even in the long-term safety outcome at 12 months of age, there were no significant adverse neurodevelopmental effects that were observed. We measured them by shock neurodevelopmental scores. So overall, we can say that Kalina study demonstrated that optimized dose of 5 milligram, 60 milligram given as 2 dispersible tablets, it provide appropriate exposure levels of artemether-lumefantrine in young infants less than 5 kg. The primary objective was met for cohort 1 because it contained the geometric mean which we had targeted based on historic exposure. The study showed that the optimized dose is also efficacious in achieving more than 95% PCR-corrected cure rate. The safety profile as well as the long-term developmental scores, they were consistent with what was observed in older children and adults. The study provided evidence for appropriate dosing of malaria treatment in infants and neonates weighing 2 kg to 5 kg. So it is high time that we start taking this neglected patient population seriously and start using optimized doses for patients less than 5 kg. Thank you.
So thank you very much. So we have done the study. We have submitted it to the Ghana FDA. We are hopeful of a positive response in approving the product. And we hope to launch the product very soon in Ghana as well. So if we have time for only one question, I have been told. So if there are any questions from anyone.
Thank you very much. He will be available during lunch. Anytime anybody has any questions, he's back there. We can go interact with. Thank you very much. Thank you so much. Closing remarks from our chair for the.
Thank you very much. You agree with me, it's been a very interesting session, and I'm going to keep it short and sweet. So I think there are some lessons that we have learned from this session, particularly about pitosis, and we talked about the acellular versus the whole cell, and clearly the issues relating to adverse events, being less reactogenic, and then also having a consistent and high efficacy are very important factors. And when you put all this together, the cost effectiveness becomes very important. And I think some of you in this room should probably need to take this app so that we can generate Ghana-specific data. For example, how does this compare to the standard of care that we have? If you give the child OPV at birth and then continue with the egg, then what happens compared to the standard? What are the titers? What are the infections averted? This will be something that will be worth looking at. Then we got into the universal health coverage, and clearly we have challenges. And one of the big ones is the human resource for health, the disparities that we have between the urban and the rural health workforce, accessibility and affordability of the service. And then also, like always, children are last in the queue, and it's important that we enhance our research so that we'll be able to generate more evidence in terms of pediatric formulations. And also, the last panel discussion cast in the mold of a case study, particularly in a rural setting, basically brings to the fore important elements. The first one is availability of essential health services, which we need to make sure is available everywhere, regardless of the location. And then it also reminds us of the importance of preventive care, not just providing curative care, but we also need preventive care as well as health education so that we reduce advent of morbidity as well as mortality. And then finally, to improve access to universal health coverage is something that involves multiple sectors. And I think all of us need to play a role. And this will require being very intentional and deliberate in doing this. We also need to be very innovative. And of course, like what we had, the Kalina study shows some innovation in terms of how to treat populations that have been neglected. With these few remarks, I really want to thank our presenters, our moderators, and then above all, you, the audience, for very good discussion. And with this, the scientific session is adjourned for lunch. Thank you.
Thank you very much. It is finally lunchtime. There are ushers in the foyer who will lead you to where we're having this the lunch, and we will regroup back here in the next. We're a bit far behind time, so give ourselves about 25. I think by 30 minutes we should be wrapping up for the last session. Thank you all, and we will be back in 30 minutes.
Hello. Yeah, so we return into this auditorium at 3 p.m. It's 45 minutes, not 25, 45. So we convene at 3 p.m. Okay. And please, coupons for the lunch have been given out. If you don't have a coupon, please stay in the auditorium. We will attend to you. If you don't have a coupon, please stay. Just be where you are. We'll come to you. Please, if you have your coupon, kindly go to Capital for your lunch. If you don't have a coupon, just remain seated. We'll approach you and give you a coupon for lunch. Thank you.
Yeah. 2, 1. Try 2. Yeah, try 2. Try 1, 2. Try 2. Try 1, 2. Try 1, 2. Try 1, 2. Try 2.
Great. PSG AGSM is finally here, and we are excited to have you here. So, in the past year, many of us have been doing wonderful things in our various facilities to ensure that child health care in Ghana is the optimum best. We have gone to some selected facilities in some regions to tell us what the success story has been in the past year.
I am Doris Nanama Asiedu, a staff of the neonatal intensive care unit at the Eastern Regional Hospital. And these are my special colleagues. Yes. So we are the NICU staff at the Eastern Regional Hospital, and we want to take you through our achievements and our journey so far. Okay. So just to start with, we just want to say a very short brief about our NICU. Yes. So we started from a very small area enclosed at the line in wall. Yes, we had only 2 cubicles, and they were very small. We had one for our in-ward, and then we had one for our referral unit. But it was very small to the extent that we were nursing babies, about 20 to 30 babies. And it was so cumbersome because while working for the babies, you see the mothers around giving feed and breastfeeding their babies, and it was all true. And then we also had a very small KMC adaptation units where mothers who had pregnant babies will go and nurse their babies there, and then do kangaroo mother care for them, as well as taking care of them and feeding them as well. And we just want to say that from there, Nana Wadie promised to give us an ultra modern building that is solely for our NICU or for the babies, where we'll have the mother's hostel. Because if we can recollect, we had a mother's hostel, which was a very small wooden structure, and the place was so packed that mothers couldn't even stay there or sleep over to come and take care of the babies there. So just to make things so simple and easy, we had to build an ultra modern facility, which includes the KMC adaptation room, 4 cubicles, and the nurses hostel or the children's room, a receptionist, and then a big hostel which was also friendly to accommodate all our mothers and make work so effective and efficient.
Since our space was very small.
So we have kitchen for our mothers where they prepare their meals and have a nice food. They enjoy their day together with washrooms. Yes. We have a thoughtful meal.
The Pediatric Society for this opportunity for us to talk about what we do at our various facilities. Holy Family Hospital is a secondary level facility and also accredited by Ghana College of Physicians and Surgeons for residency and fellowship training in pediatrics and OBGYN. It is a 350 bed capacity with pediatrics occupying.
Here in the Oswejiman district of Ghana's eastern region, you can test your mental resilience against
Hello.
Good afternoon. I hope we all had a lovely lunch. Can we please kindly regroup for the last session? Can we please kindly regroup for the last session? Thank you.
Can we have our seats, please? Good afternoon, everyone. Welcome back from lunch. I remember earlier today, Dr. Kesuwa said that when you get to the ward, you get to know that the ward is for nurses. So I'm a nurse. I am Mavis Insia Santini Kokro, a neonatal nurse resident. And I'm honored to be here. I would like to begin with a Bible quotation from Colossians 3:23 to 24. Whatever you do, work at it with all your heart, as working for the Lord and not for human matters. So a round of applause to all of us for our sleepless nights, long working hours, diverse support to uphold the well-being of children in Ghana and beyond. Pediatric Society of Ghana is proud and they seek for the well-being of children. Today, we would like to acknowledge the hard work of some distinguished personalities. With me to do this is Dr. Claudia Ejase. A round of applause for her. We would like to say more about these distinguished personalities, but sake of time, we would have to round it up. To begin with, in no particular order, the Education and Training Award. Dr. Williams Apiedu-Mensah. A round of applause. He is a distinguished medical professional, married with 2 adult children. He is currently a post-retirement senior lecturer in the Department of Surgery at the University of Ghana Medical School and a consultant pediatric surgeon and a pediatric urologist at the Kolebu Teaching Hospital. His career began at Konfanochi Teaching Hospital in 1988 to 1990 and St. Teresa's Hospital in Kransa 1990 to 1999, becoming a consultant and a lecturer at the University of Ghana Medical School from the year 2000. Since 2012, he also manages patients at the 37 Military Hospital. He is also formerly the head of pediatric surgery at Kolebu, a chairman of Faculty of Surgery and Subspecialties Ghana. Dr. Apiedu-Mensah has extensive experience since 1996, managing diverse pediatric surgical cases, publications, and 11 presentations, and participated in international multi-center studies. Congratulations, sir. We appreciate your many years of training doctors in Ghana. Aiko. To assist to present this award is Dr. Sego Moses. A round of applause for her too.
Okay, thank you so much, sir, and thank you, ma. The next, okay, let's allow him to sit. Thank you so much, Dr. Apiedu. The next category is Special Honorary Membership Award. And this goes to Professor Ifwa Hesse. Professor Ifwa Hesse is a distinguished figure in medicine, having over 41 years of experience. That's like somebody's whole lifetime. As a pediatric surgeon, medical educator, and hospital administrator across the UK and Ghana. Her pioneering spirit is evident in her numerous firsts. She made history at the University of Ghana Medical School in 2011 by becoming its first female professor of pediatric surgery. Since 2015, a significant part of her legacy has been as co-founder and president of the Accra College of Medicine, Ghana's first private medical school, which graduated its inaugural cohort of doctors in 2020. Professor Hesse's dedication to service is further exemplified through volunteer surgical missions and numerous awards, including the Millennium Excellence Award for Medical Leadership, among several others. Mommy, we say Ayiko. I'll ask Dr. Sego Moses to continue to do this presentation for us. Let's keep clapping as she comes. Let's keep clapping, keep clapping. You are tapping into her grace so that someday.
Next, we have Pediatric Leadership and Governance Award. And it's going for no other than Prof. Al-Hassan Abdul Mumin. A round of applause. He is an associate professor and consultant pediatrician who has worked for over 14 years at the University of Development Studies and the Tamale Teaching Hospital. He earned his undergraduate medical certificate at Gazi University of Medicine, Ankara, Turkey in 2005, and his certificate of specialization in pediatrics and child health at Hakatep University School of Medicine, Ankara, Turkey in 2010. He has over 50 peer-reviewed publications. Wow. Leads research teams in the conduct of clinical research. Currently, he is the Director of Medical Affairs at the Tamale Teaching Hospital. Shall we have Prof. Al-Hassan? Shall we also have Dr. Adabayiri to help us present this award? A round of applause. Thank you. Education and Training Award, there is still another person. Dr. Ajiri Saki, a round of applause. He is a product of Infansipim and the University of Ghana Medical School. His early career jobs were in the Kolebu Teaching Hospital, Children's Department, and a hospital in Nigeria. He then relocated to England and from 1994 worked as a consultant in pediatrics, receiving an NHS Clinical Excellence Award. He is spending the early years of his retirement sorting out his photographs, videos, and time lapses of landscapes, birds, flowers, street events, and clinical materials. Dr. Saki, we celebrate and appreciate your contribution to education and training the pediatric workforce in Ghana. Well done. To do this presentation, we have Dr. Mami Anyako. A round of applause for her as well. Are we tired? Let's give it up to them.
Okay, so we move on to citations for some distinguished friends of the Pediatric Society of Ghana. And not in any particular order again, we have Kwame Sefa Kai. Mr. Kwame Sefa Kai, in recognition of your outstanding dedication and unwavering commitment to advancing child healthcare in Ghana through the Kokroko Charities Foundation, your visionary leadership in launching Project 100 has significantly improved and strengthened neonatal care in Ghana, providing life-saving incubators and essential medical support to hospitals across the country, giving preterm babies an improved fighting chance to survival. I think we should clap to this. This has left an indelible mark on countless families and communities. With profound appreciation and heartfelt gratitude, we celebrate your remarkable impact and honor your steady efforts in shaping a healthier future for Ghana's children. Mbonaye, thank you so much. To do this presentation for us is Dr. Abekwe. So after he receives his citation, he has a few words for us. My ears are itchy. I hope yours are too.
Forgive me for breaking protocol. I just wanted to say a few words. I'm honored that Professor Hesse is here. I'm honored because a little over 10 years ago, when we started Project 100, she was one of the first people we ran up to. And we said, Prof, this is what we want to do. Guide us. And anybody who's worked with Professor Hesse knows she was more than excited to help. We had no knowledge in medicine. We knew nothing. It was my partner, the gentleman seated next to me. His name is Dennis Educhu. And it was Dennis and I who cooked up this idea. And so we went to Prof, and Prof gave us all the guidelines, gave us the data, the information, and actually appeared on my radio show, Kokroko, to kind of help us make a little noise about it. Prof, I am honored that today you are here, and I want to say thank you. Thank you so very much, Prof. And interestingly, I noticed that Professor Mumin, where's he? Tamale Teaching Hospital, Prof. I remember when we came to Tamale, so our desire or our target is 100 incubators. In the last 10 years and a little, we've done a total of 62. And Tamale Teaching Hospital, we're proud to say we gave you 3. We've given you 3 so far. And to see you up here for recognition gladdens my heart. Dennis, should I promise another 2 for Tamale? So I saw the work Prof. Mumin and his colleagues were doing and are still doing in Tamale, and the conditions under which they work. And Prof, congratulations. I was going to promise 2, but Dennis says I should be careful. So you hold on to your 3 for now, and we'll see how it goes. We've done 62, as I said. It's been difficult raising funds, but we've done our bit. And we've also added a mother's unit at the whole teaching hospital. Because when we went to the whole teaching hospital, Prof. Mumin, we stole the idea from you, let me be honest. When we came to Tamale, we realized you had created a mother's unit. It wasn't that big, but it was comfortable enough. So we've stolen a bit of your idea and polished it. We're taking it to Ho, that's Trafalgar. So we're actually going to start, we'll break ground in a few weeks. We'll build a 60-bed mother's unit at the whole teaching hospital, all as part of what we're doing for Project 100. So my biggest thank you goes to the Pediatric Society of Ghana. Thank you very much for acknowledging our work. I know I am the face of it, but there are so many people who support us. We appreciate this. It will spare us on some more. Thank you all and enjoy the rest of your day. Thank you. Thank you very much.
We'll take the last award for now. Pediatric Advocacy Award. No other than the owner of award, Joyce Mauna Apau. A round of applause, a big one. She is a proactive nurse who is currently working at the Trauma and Specialist Hospital in Winnipeg. She has been a phenomenal nurse with some of her key achievements, including championing the establishment of neonatal intensive care units at the Trauma and Specialist Hospital and the Mercy Women Catholic Hospital. She is also currently a member in training at the Ghana College of Nurses and Midwives. She is admired for her advocacy and innovation. There you have Joyce. To help present this award is Dr. Christiana Osei-Yeboah. A round of applause for her as well. Let's do it better.
Thank you so much, Joyce. Please don't go yet. She will just say a word, and after that, all our Ds for this session will please come up stage for us to take a good picture with NEC and LOC. Thank you so much.
My first thanks go to God Almighty for having seen me this far. And I couldn't have been here today. I don't know whether Dr. Najama Glover is here. I am a pediatric nurse and neonatal nurse in the making because of Najama Glover. And I thank her so much because I was just a mere nurse working in the pediatric ward, just fighting to make sure these children survive. But I didn't know that she has identified something unique in me. I didn't have even the idea of becoming a pediatric nurse in the first place. But with her zeal, with her words of encouragement, here I am today. And I know God has so much for me. And all I pray that God should help me to achieve whatever I have planned to do to save the children that are less privileged, that don't have a voice. All I want to be a voice for them so that together we build a mother Ghana. Thank you.
Congratulations. Joyce, kindly wait. Can we have the awardees for the picture? And the LOC as well. Upstage, upstage. LOC and the awardees. The executive too. Can we have Ifia Mankwa Tamaklo here as well? And Mr. Albert Ankra. Abigail Konto, if you are here, kindly come up stage.
All right. So we had a few more to do, and I've been told that everyone here is present. So we'll just finish it up and then all right. So the next citation goes to Mr. Albert Ankra. Shall we give it up for Mr. Albert Ankra? So this comes in recognition of your visionary leadership and dedication to advancing child health care in Ghana and beyond. Through Africa Health Supplies, you have pioneered the local assembly of Firefly phototherapy equipment, improving access to life-saving treatment for newborns with neonatal jaundice. The Pediatric Society of Ghana values your partnership and congratulates you on your hard work and relentless pursuit of excellence in medical innovation. Congratulations. And to take his award for us is
Bien Ankra, Deputy CEO of Africa Health Supplies, and then his wife as well.
the 2 are one. So to present this award for us is our very own Professor Enchi. Let's give it up for Prof as he comes.
We would also like to recognize the efforts of Efia Amankwa Tamaklo. In recognition of your outstanding dedication and commitment to maternal and child health advocacy in Ghana, your unwavering efforts in raising awareness, educating the public, and amplifying critical health issues have significantly contributed to improving the well-being of children across the nation. On this occasion of our annual general and scientific meeting, the Pediatric Society of Ghana expresses its deepest appreciation for your remarkable contribution and passion towards child health and well-being. Wired, GA. Prof. Welbeck, kindly assist us present this award. A round of applause for him as well.
So thank you so much. And well done. Keep up the good work. So the last but not the least, we have Abigail Kunto. Shall we please give it up for Miss Abigail Kunto? In recognition of your outstanding dedication and commitment to child health advocacy through the Cradle to Crayon Foundation. How many of us have been listening to? Yes. And the Cradle to Crayon show on Sunny FM. Your commitment to early childhood development, child nutrition, and health literacy have significantly influenced the lives of many children in Ghana. The Pediatric Society of Ghana celebrates your invaluable contributions and proudly honors your unwavering passion for child health advocacy. We say Ayiko. And to do this for us is our very own Dr. Fatima Kelba. The only Obroni in pediatrics. Thank you very much. Thank you for your time. We will continue with the rest of the sessions. We'd like to introduce the chairperson for the next session, which is our abstract presentations. I'm sure we are all ready to hear the great work that our colleagues and senior colleagues have done. And to chair the session for us is none other than our very own Dr. Lako. Please let's give it up for her. Our special mama in the house. Okay. Thank you very much.
Before we start the next session, we have Phillips, one of our wonderful sponsors here, to give us a 6.5-minute presentation. Thank you.
Good afternoon, ladies and gentlemen. My name is Delali Alimot-Sadia, and I'm representing the company Abbott. And today we are going to be talking about microlights, Classed in particular. And Classed is our brand of clarithromycin. We are innovators for the product Brufen. So I'm sure every single one of you here know the product Brufen. And we are innovators of clarithromycin, which is Classed. Okay, so we all here would agree with me that Classed exerts a broad spectrum of antibacterial activity or action against aerobic and anaerobic organisms in the treatment of skin and soft tissue infections, upper and lower respiratory tract infections, and then the complete eradication of H. pylori in duodenal ulcers. Since I've been at the booth since yesterday, every person that comes closer to my booth tells me, oh, we use clarithromycin for H. pylori. So everyone here agrees that clarithromycin is part of the triple and quadruple therapy for H. pylori eradication. But then there's a recommendation that says there's supposed to be a 14 days treatment, twice daily dose, and it gives like an up level of eradication than the 10 days, which is 84.4% versus 78.5%, comparing the 14 days dosing and then the 10 days dosing as well. Okay, the WHO guidelines as of 2023 puts clarithromycin as the first choice when it comes to community-acquired pneumonia, and then the second choice for pharyngitis. So there was a comparison between clarithromycin, which is our Classed, and azithromycin in sinus fluid concentration. And with this, the conclusion was that clarithromycin achieved a significant higher concentration in both the serum and extracellular tissue compartments in patients with RBS. Classed gives a higher potency of 2 hours after administration, and then it has a more activity against S. pneumonia strains compared with azithromycin. So then you might ask, why exactly should you choose clarithromycin or Classed? So over the years, there have not been the existence of clarithromycin suspension in our pediatric treatments. But then from Abbott, now we do have clarithromycin suspension in 125 per 5 milligram and then 250 per 5 milligram. Classed has a shorter half-life compared with azithromycin, which is 3 to 4 hours, whilst azithromycin's half-life is 2 to 4 days. There is a Dove press study, which I have the hard copy at my booth that is available for every single one of you here. There was a comparison of the resistance rate of all microlides. Now, post-treatment, first week post-treatment, all microlides were having a higher resistance rate of about 90%. And then 6 weeks post-treatment, comparing azithromycin and clarithromycin, azithromycin still had a higher rate at 85%, but then clarithromycin post-treatment 6 weeks was 17%. So this Dove press study, I'm saying I have a hard copy at my booth. So if any person here wants a copy of that, I'll be able to provide that as well. So most generic of antibiotics have this bitter taste after they take it. But with ours Classed, it has this cocktail fruity flavor that when the child takes it, it's easier for them to be able to consume it, and it doesn't need to be refrigerated as well. Now, these are the dosing for the Classed. We have the adult version, and today, because we are at pedic section, we'll be talking about the pedics. Like I said earlier, there's 125 per 5 milligram and then 250 per 5 milligram available on our side. We also have the IV as well. So yesterday, I had a conversation with one of you here, and she was like, she had a patient on gastritis, which was H. pylori positive. If she had known that there's availability of clarithromycin IV, she would have used this. So I'm telling you today, there's an availability of clarithromycin IV. That is an option for you to choose from. Thank you very much.
Hello, this one works. Okay. My name is Michael from Vice Pharma. I'll not take much of your time. I've been signaled that I have short time. So I'll just go straight to the point. Yesterday and today at our booth, we discussed with some doctors that approached us, and their findings, it looks like it goes well hand in hand with the International Society of Health publication 2023. That states that most children that comes to the consulting room, 51.3%, in summary, they don't eat. Two of us. For one reason or the other, they hardly eat. Lack of appetite is something you face. But we all know that these children need to eat food to be able to get the nutrients that they need for their day-to-day activity and for their development. So how do we get them to eat? Welcome to Dynamogy. This will help the children above 2 years to eat and get the energy and development that they need. Maybe you may ask, what does Dynamogen contain? Dynamogen contains 2 active ingredients. 3 milligram of glutathione, and then 1 gram of arginine aspartate. What do they do? 3 milligram of glutathione stimulates appetite at the appetite center of the brain. That helps the children to eat and to eat very well. And so we are giving them glutathione to help them eat. So when the children eat a lot of food and the food is in their stomach, how do they get the energy from it? That is where arginine aspartate, which is one of the active ingredients, come in. We have 1 gram of arginine aspartate, which activates and helps in the synthesis of ATP. And we know ATP is the major energy point from the body. So we are giving energy, we are giving appetite. And the food that we eat too, the arginine aspartate, is able to enhance the Krebs cycle. Like we all know, in Krebs cycle, I'm being notified. In Krebs cycle, it helps in the generating energy from the food we eat. So in Dynamogen, ladies and gentlemen, and fellow healthcare professionals, we have a product that will stimulate appetite for your children who doesn't eat or who don't eat at all or who have bad eating habits. And then in the same process, same product is giving them energy. And that's what Dynamogen does. Dynamogen works in three folds. It helps increase the height, the weight, and it works faster than any other anti-anorexics on the market. Yes. So when we are talking about Dynamogen, it will help increase the height by 25% more than any other anti-anorexic on the market. Yes. Yes. So I saw this, the nurse from the trauma and the specialist from Winneba. I think everybody can ask her. Yesterday, she gave her daughter Dynamogen 10 meals. And today she was telling me, is that the boy is eating? Yes, please. Yes. So that's the wonders Dynamogen is doing. And it can increase weight by 15% more than any other anti-anorexics. It helps increase weight by 15%. So when we compare Dynamogen to cyproheptadine, Dynamogen to arginine aspartate monotherapy, you can see in the graph down there, within a month, there's 2 kg weight gain using Dynamogen. So how do we use Dynamogen? Dynamogen looks like this. It's in a 10 ml ampoule form. So for kids older than 2 years, you give 1 ampoule per day, preferably 30 minutes before food. And you see the wonders I was talking about. And for adults, even though we are in the pedics, adults too can take Dynamogen. So if you want to eat, you want to be energized, so you can take Dynamogen and it will energize you. So adults can take Dynamogen up to 2 ampoules per day. And so, ladies and gentlemen, fellow healthcare professionals, yes, if you are looking for the solution for the children to eat, don't call anything. We have Dynamogen, and it's available in all our pharmacies to purchase Dynamogen. Thank you so much. My name is Michael Wasik.
Thank you very much, Mr. Dynamogen. We move on to our next session.
Good afternoon once again.
Hello.
Okay. Good afternoon once again. Welcome to the last session. We are far behind time, but I think that we'll have a little energy to be fast enough. So, like they said, I'm Dr. Lako Owusu, and I'll be chairing the presentation of the abstracts. So I'll start by asking Dr. Yakubu to introduce our judges, and then I'll introduce the presenters, and then give you the housekeeping rules. Thank you.
Yes. All right. Good evening to you all. Time is fast spent. I'll quickly introduce the judges for this session. So in no particular order, the first judge is a professor of pediatrics with the Kwame Nkrumah University of Science and Technology, former dean of the School of Medical Sciences, and he's in the person of Professor Daniel Anson. So Prof. Anson, can we have you come forward? So as he joins us, I will introduce the second judge, who is a consultant infectious disease specialist with the Kolebu Teaching Hospital and a senior lecturer with the University of Ghana Medical School. She's in the person of Dr. Joycelyn Dami. Last but not least, we have the medical superintendent of the Princess Marie Louise Hospital, a former president of the Pediatric Society of Ghana, Dr. Mameya Nyako. So they will be helping us assess the presenters of the abstracts for this afternoon. Thank you very much.
And our presenters also in no particular order. Matilda Kumaho, and her presentation is on caregivers' willingness to receive care for ward outside Department of Child Health, Kolebu Teaching Hospital, a pilot study. And then there was no title by this one. Schroeder Portal, assessing the completeness and accuracy of EMR data in a teaching hospital in Ghana. I presume from Kolebu Teaching Hospital. Okay. Dr. Rosemary Safako Akuaku, inhaler device use among children attending the pediatric asthma clinic, Kolebu Teaching Hospital, a descriptive study. Dr. Emmanuel Pabi, multinational antimicrobial resistance surveillance, lessons from ACON 2 site at 37 Military Hospital, Accra, Ghana. And Dr. Haruna Mahama, a lifeline for little lives, a newly established pediatric hemodialysis unit to bridge the gap in renal care from Fontana to Teaching Hospital. And our housekeeping rules, each presenter has 10 minutes and will be prompted at 7 minutes by Dr. Yakubu. Have the first 3 presentations and then have a 5-minute break for questions. And then presentation of 2 draft presentations and go back onto the last 2 papers. And then have another 5 minutes for presentation, for questions, sorry. So we'll invite the first presenter, Matilda Kumaho. Dr. Matilda Kumaho.
Good afternoon, ladies and gentlemen. My name is Matilda Kumaho, and I'm presenting on caregivers' willingness to receive care for their wards outside the Department of Child Health in the Kolebu Teaching Hospital, and this was a pilot study. So the Department of Child Health runs 10 subspecialty clinics, and we see patients from all over the country. And we also see a lot of patients coming to us being referred all over. In 2023, we saw about 15,000 outpatients coming in for subspecialty care. And out of this, about 2,500 of them were new cases. And these patients also experienced long waiting times, despite the fact that an appointment system was introduced to improve healthcare delivery. Many studies have shown that positive patient experiences with healthcare delivery are associated with good treatment outcomes. And some of the experiences involve interactions with all aspects of the healthcare system. The quality of these interactions are determined by elements such as health information, timely appointments, and then when there are clear communication between the providers and the clients. So still in the spirit of universal health coverage, we want to ensure that every patient we see receives excellent health care or quality health care, and they should not be exposed to any financial hardships. So if patients have to travel long distances to receive health care or spend a lot of money on transportation to receive health care, then the universal health coverage is not being properly utilized. So the objective of this study was to assess caregivers' willingness to receive pediatric specialty care at alternate facilities and whether they preferred other clinic times. It was a cross-sectional study which we conducted on 163 participants, which we recruited them from the Department of Child Health Subspecialty Clinic in December 2023. And we used structured questionnaires which were randomly administered to the caregivers. And at the time, we had 9 of our specialty clinics running. One of them had closed for the year, the gastroenterology clinic. The data we gathered was entered into Google Forms and then was analyzed using Excel spreadsheets. So these are the results we had. Like we can see, there was almost an equal number of the sex distribution of the respondents, the words of the respondents that we interviewed. We see patients from the graph, we see patients all the way from the neonatal period all through to adolescence. But most of them are clustered around the from under 5s to up to adolescent age, up to about 15 years of age. Sorry, I think the pointer has. Okay. So most of the patients we saw came from the Greater Accra region, almost 80% of them. And this could be explained by the fact that Korle Bu Teaching Hospital is located in the Greater Accra region, and it's a major referral center. So we expected that a lot of them will come from the Greater Accra region. However, we can also see that about 21% of them came from Central region, some as far as the Upper East region. And that was also significant. To travel all the way from Upper East region to receive care at Korle Bu Teaching Hospital, we thought was a lot of stress for the patients. So for the clinics attended, most of them attended the neurodevelopmental clinic and the sickle cell clinic. I must say that these are some of our heaviest clinics that we run in the department. And for how long they had been with us at the clinic, most of them, about a quarter of the respondents had been with us for more than 5 years. But then we see that about 28% of them had been referred to us less than 3 months. So we asked, could these patients have received healthcare maybe at alternate facilities, even if it is within Greater Accra region? There are other facilities with pediatricians which could have offered specialist care to these patients. And for them, for this graph, it shows that a lot of the patients arrived at the facility. About 38% of them arrived in less than an hour to the facility. However, we also see about 21% of them spending more than 2 hours to arrive at the facility, which was a lot of time. And for reason for choosing the clinic, a lot of
You
them
have
said
4
they were
minutes
just
more.
referred, so they were there to receive their clinic visits. And for the average time they spent at the clinic, majority of the patients we saw spent more than 4 hours. That's about 38% of them spent more than 4 hours. A study that was done in Malaysia showed that patients were dissatisfied if they spend more than 2 hours at the clinic to be seen by their healthcare providers. And so we asked, if you were given the option of getting the same service somewhere else in another facility, would you go? And 52% of them said yes, would go and then receive the clinic to cut down on their waiting times and other factors that would prolong their stay in the hospital. And most of our patients said they still preferred the morning clinics when we asked them. So some of the findings are that majority of our caregivers were from the Greater Accra region, but we have to also note that significant numbers came from the Central region, Eastern region, and then as far as the Upper East region. And only 11% of them reported that they spent less than an hour at the clinic. More than half said they were willing to attend these same subspecialty clinics if they had the services rendered elsewhere, provided they were qualified doctors or healthcare providers. So in conclusion, this pilot study demonstrated caregiver willingness to receive specialized care outside the Department of Child Health. There's the need to empower other facilities, which are pediatricians, to establish or improve their subspecialty clinic. And this would also help for us to achieve the goals of the universal health coverage. As a cross-sectional study, we could not make inferences on cause and effect, and we couldn't conduct in-depth interviews to get more information on some of the choices that the caregivers made. So we recommend that we'll still maintain our morning appointments, but we'll strengthen them and enforce that patients keep to their time so that when they come to the clinic, they do not spend a lot of time. And for facilities that do not have subspecialty clinics, we encourage that we set up one. And then we'll also conduct in-depth interviews in any future research to obtain more information on patients' choices. I acknowledge the subspecialty clinic staff and then the patients and their caregivers. And these are my references.
Thank you very much, Matilda. You did 9 minutes.
Thank you very much. Our next presenter is Dr. Schroeder Hoto.
Good afternoon, distinguished guests and ladies and gentlemen. My name is Schroeder Hoto, and I'll be presenting on a study titled Assessing the Completeness and Accuracy of an Electronic Medical Record System in the Neonatal Intensive Care Unit at the Teaching Hospital in Ghana. These are my co-authors, and this is the outline for the presentation. These are some abbreviations we'll be encountering during the presentation. I have no disclosures. So the electronic medical record system has potential to improve healthcare delivery, research, and to drive policy. The effectiveness of an electronic medical record depends on its completeness and accuracy. Now, Kolebu Teaching Hospital NICU is one of the largest NICUs in Ghana, and it transitioned from a paper-based record system to an electronic record system in September 2021. So after its transition, there has been no study to compare the electronic medical record to the paper-based medical record. So our study seeks to assess the completeness of the electronic medical record and its accuracy. And then by way of specific objectives, we want to assess the completeness of newborn data available in the neonatal EMR, comparing it with the paper-based records. And then to assess the accuracy of newborn data available in neonatal EMR compared with PBR. To assess the completeness of maternal health data on the neonatal electronic medical record compared to the paper-based record, and then to assess the accuracy of maternal health data on the neonatal electronic medical record, comparing it to our paper-based record. Now, our study is retrospective, and as I said earlier, we're comparing the electronic medical records, the paper-based records, and the duration of the study was 1st June to 31st of December 2022. And we're looking at the NICU admissions during that period. The sample size, we calculated using the Kappa statistics sample size calculation using the Stata version 16 with the confidence interval of 95%, and we got 222 for that. Now, the newborn records with both paper-based and EMR were randomly selected and then de-identified. Now, we predefined 54 clinical variables, which we assess for completeness in comparing the EMR data with the PBR, and then the accuracy of the EMR with the PBR using as PBR as gold standard. So our inclusion criteria was newborn electronic medical record data who had corresponding paper-based record during the period of the study. And we gained ethical approval for this study from the institutional review boards of Kolebu Teaching Hospital and then the Children's Hospital of Philadelphia. So this is a summary of our results. A total of 222 newborn records were analyzed, and the definition for completeness was number of filled fields. So the total average of our data for completeness for paper-based records, we had 73.5%. And then for the electronic medical records, we had 28.9%. So you can see that the electronic medical records were lagging behind in completeness. Now we broke down the data to categorize them under the neonatal NICU data, neonatal NICU referral data, maternal referral data, and delivery details. And you can see the same trend. The paper-based the percentage for completeness for paper-based records is still higher than the electronic medical record. And this is just to show us some variables that fell under the predefined 54 predefined variables we examined. So as from this graph, you can see apart from sex, time of birth and birth weight were statistically significant. And you can see that EMR is lacking behind. But with the sex, they were a bit close, although EMR was still low. And this we can explain this because the sex is required as part of the registration process when they're creating the EMR. When they're registering for when they come to the clinic and have to register, then at the registration point, they have to input sex. So you notice that this data will not be put in at the NICU. So this is also to examine more variables. And this is looking at the maternal referral data variables. So we have maternal age, A and C steroids given insurance. Now, one thing to note here is that the EMR data is higher here. We have 100%. And this is because insurance is required as part of your registration. And most of the mothers are insured and it covers the babies. So obviously that will be high. So further looking at the delivery variables we analyzed, here the same trend is observed, where paper-based records is in the lead, and then our EMR is lagging behind. And all this was statistically
You have
significant.
3 minutes, 30
Okay,
seconds.
so for accuracy, basically we defined accuracy as having the number of fields that contain complete, valid, and concordant data. Now, validity means that the data matches what we find in the real world. So if I was looking at a data variable as age for a neonate and 30 years was inputted, then I would see that that is not valid. Concordance also was just to see if the data fields match the EMR and the PBR data match. So although it could be failed and complete, once there's a mismatch, we'd say they're not concordant. Okay, so 100% concordance was observed for a month of record, and then similar trends of validity was observed for completedness. So the EMR showed that it was, our data showed EMR is less complete than the paper-based record. And the main challenge for our EMR was, you notice that there was a lot of missing data, and the majority of the variables that were entered in the EMR were actually accurate. So now we were done with collecting data, we're still analyzing the data. So the next steps for us is to compare or go further to compare the neonatal data versus maternal data, but we're still looking at paper-based and electronic medical records. And then to also look at the NICU-generated data versus the referral site data. And we want to ask, can this help target EMR quality improvements? Can it help us find where the quality improvements are needed more? And then also, we would like to identify and analyze a subset of variables that are deemed to be critical for care across EMR and PBR. So for our conclusion from the study is that at the time, Kolebu Teaching Hospital's NICU EMR is generally not accurate, it's generally accurate, but it's incomplete. And the EMR currently, at the time of research, was not reliable for research and then key performance indicators. The EMR data entry protocols must be improved and strengthened, and collaboration is needed between hospital technology team and health workers in the NICU for full transition from the paper-based records to the electronic medical records. So I'd like to acknowledge the Kolebu Teaching NICU team, and then also acknowledge our collaborators for their support, and then the research assistants we work with. Thank you.
Very much. Our next presenter is Dr. Rosemary Ekuaku.
Okay, good afternoon, ladies and gentlemen. I'd like to begin my presentation with a short story. So one day, Dr. House, a fantastic diagnostician in a popular medical series that I like to watch from time to time, was assessing a patient who had asthma and came with a complaint of poor control of her symptoms, although her medications were running out very often. He asked her to demonstrate her technique, and she asked him, "Do you think I'm an idiot?" And he simply said, "No." So then she went on to demonstrate how she does it. So she shook her inhaler and she sprayed it this way. And she was so happy with herself. And he looked at her and was like, "Oh my goodness." So ladies and gentlemen, I'm about to present a study that has similar findings, but our patient didn't do what she did. And my name is Rosemary Ekuaku. I'm a pediatric resident at the Kolebu Teaching Hospital. So the title of my study is Inhaler Device Use Among Children Attending the Pediatric Asthma Clinic, Kolebu Teaching Hospital, a descriptive state. I have no disclosures to make. This will be the outline to guide my presentation. So, childhood asthma is the most common chronic non-communicable disease in children. Inhaled medications and their devices, example, the metered dose inhaler with the use of the spacer or not, the discus and turbohaler are the backbone of effective asthma management when used appropriately. The aim of the design of this therapy is to deliver the medications directly to the lungs at a reduced dose as would have been required if we did it systemically, leading to less systemic side effects. However, it has been reported that many children with asthma incorrectly use their inhaler devices even after comprehensive instructions are given, and this leads to poor asthma control. There is paucity of published data on inhaler device techniques in children attending asthma clinics in Ghana. The knowledge from the study that we have done will provide evidence that will help in the formulation of policies and management guidelines for asthma care and serve as the foundation for further research in this area. So our objective was to assess inhaler device technique among the children and or parents attending the pediatric asthma clinic at the Kolebu Teaching Hospital from February 2018 to May 2019. So originally, our study was designed as a hospital-based 1:1 age and sex matched case control study. And it was to determine the factors associated with emergency department visits by children attending the asthma clinic in Kolebu Teaching Hospital. The study recruited a total of 110 participants over the period. 55 were cases and 55 were controls. A case was defined as a patient who visited the emergency department at least twice within the period, about 12 months of being interviewed, whilst a control was a child who had at most one visit to the emergency department. For the objective of the study that I'll be speaking about, we analyzed the data as a cross-sectional study, since the outcome that we were looking for, which was inhaler device technique, was not considered as a matching variable at any point or sampling the patients into the database. So using a semi-structured and interviewer-administered questionnaire, data was collected on social demographic details and clinical characteristics of the patients. We assessed the techniques of the patients using a standardized checklist, and those who were deemed to have appropriate practice were those who were able to go through all the correct steps. And after we got the data, we did descriptive analysis. So let's discuss our results. Sorry, it's not big. Oh. Okay, so let's discuss our results. Okay, so the median age of our children were 7. And if you look here, most of the participants were between the ages 5 to 9 years. There was a male preponderance with a ratio of about 1.4:1. And most of our parents had at least secondary level of education. Yes, thank you. Now, for the level of control, majority of our participants had good control. And we are very interested in those who had poor control because we know that those are the ones that tend to have poor asthma control. And from our study, which we realized correlated with what we found in literature, we noticed that a lot of our patients had a poor technique. And so because they were having the poor technique, that's what was contributing to them having poor asthma control. Then for the inhaler device technique amongst the participants, we realized that 66.4% of them had inappropriate technique use. And that's what we will discuss further. So majority of our participants had an inappropriate technique, which was what contributed to the poor asthma control that I had mentioned earlier. And according to a study done by Al-Jadali et al. In Saudi Arabia, they noticed that about 45% of the patients they studied, and that was in an adult population, they had poor technique. And especially when we go through literature, you realize that studies done in children, they also had poor technique. And that's not surprising because the children depend on the adults to help them deliver the medications where the medications are supposed to go. So if the adults are having poor technique, then the children will most likely have poor technique. In a study done by Kamps et al. In Netherlands and Chen et al. In Taiwan, they realized that to put the observation, they also observed
You
how
have 3
children,
minutes, 30 seconds.
okay, when they observed how children use the devices, they realized that theirs was also poor, and they put their range at 8 to 22%. Now, when we compare the use according to the device, that's you have the metered dose inhaler, you have the dry powder, which is the discus, and the turbohaler, you realize that those using the metered dose inhaler with or without the spacer device had poorer technique. And that was also consistent with what we found in literature, because we realized that it was more difficult for the children, especially those below the age of 6 years, to use the metered dose inhaler. And the spacer made it a bit easier for them. For those who use the discus and the turbohaler, they had better use because the steps there were fewer. So this was a checklist that we used. So for those who use the pressurized metered dose inhaler without a spacer device, we realized that they had challenges in their inhalation technique. And from this, you can see that those areas, they had higher people not demonstrating appropriate technique. But for those who use the metered dose inhaler with a spacer device, their technique improved. And their challenge was only after they had used it, because then they tended not to wait in between the puffs. Now, for those who use the discus and the turbohaler, most of them had appropriate use. And I think the reason why we're seeing what we're seeing because our numbers were fewer. And we know that usually for the treatments of asthma, we usually tend to start with a metered dose inhaler. So in summary, for our study, we realized the majority of the children attending the pediatric asthma clinic may be using their inhaler devices inappropriately. And unfortunately for us, we are unable to generalize our findings to the whole population because of our small size and because it was a single center study. We also did not assess the factors that were associated with inappropriate technique. And we also did not assess the knowledge and the skills of the healthcare provider. So we recommend in next studies that we study those factors and also assess how healthcare givers, our knowledge and our skill in the use of the inhaler device techniques. So I will end. So our take-home message is that as we go home, we should note that inappropriate inhaler device technique, when it's not used well, can contribute to frequent acute exacerbations, which will lead to poor control of asthma, which will place a higher burden on the family, on the healthcare system as well. And as healthcare providers, we have a role to play. Thank you.
Thank you very much. We'll take a short 5-minute commercial break with a presentation by Africa Health Services, and then we'll continue with our presentations.
Good afternoon, everyone. My name is Dr. Audrey Chepkemoy. I'm a pediatrician and a neonatologist. I want to make a short presentation on behalf of the Hatch Technologists, and we work together with AHS, the African Health Supplies, who are our distributors in Ghana. So Hatch Technology is a non-profit organization that actually helps to improve maternal and newborn solutions. Basically, in Africa, it originated from Nest 360, for those who know Nest 360. And it's our mission, as we said, is basically to transform maternal and newborn health technologies and the way the technologies are distributed in Africa and beyond. And it's an NGO that is registered in the US, but its headquarters is in Kenya. So that is about Nest 360. Just to remember that it's an organization that it's 20 organizations together with several objectives to deliver and sustain innovations, to develop an educational ecosystem, and to improve the way evidence-based medicine is practiced in the newborn ecosystem. And then, why Hatch was brought about is because of some few challenges, and the challenges I want to rush because I've been given a little bit of time. So that we found out that there's challenges in the way health and maternal and newborn technologies are accessed, and also it's actually unaffordable, most of the technologies, and most suppliers didn't want to equip newborn technologies because of the cost, but then the people were not buying as much. And then we also noticed that there is limitations in the way newborn technologies are maintained and supported. And also there is also lack of training for the users and also the awareness. So what are our solutions? The solutions Hatch Technology offers is that we have a sustainable and effective logistic and procurement process. And the way we support it, we support the way we have a system where we select high quality equipment that can be able to survive within the African ecosystem, so that they're able to survive within our systems with high temperatures, with humidity and the crowding that is in our units. And then we actually have a way of forecasting for inventory, and we have a system that we can support units to be able to forecast on their whatever their requirements are. And then we also do aggregation. We look for all the suppliers like in Africa, the ones that we have, and then negotiate the price for them at the manufacturer level, so that it's able to bring the prices down and they are able to have the equipment at a cheaper price. And then we have the comprehensive distribution and technological support. So the way we support that we not only distribute the equipment, but support the training and the maintenance, and also provide continuous mentorship to avoid the equipment from landing into graveyards. And then the last way we do, so the other way is basically we avoid the graveyards for equipment that are common. We know that up to 40% of equipment in Africa end up in graveyards. So we try and avoid that as much as possible by also just making sure that the equipment are well maintained, there's preventive maintenance, and we have a way of tracking equipment all the way from the time they are equipped and brought into the facility to the way to decommissioning, so as to avoid processes of having equipped graveyards. And then the other way we support the manufacturers by giving them a working capital, so that they are able to continually work and have a working capital. And in Ghana, we are working with AHS currently to just support them, and they are also supporting us. Okay. So the way we monitor our equipment, we have what we call Asset Infinity. It's a web-based app that we use to monitor our equipment all the way from the manufacturer to the user and until the end of its life cycle at the end. And that's how basically, this is one of the sites in Kenya, and it's each of those that you can see is each of the hospitals, and we're able to monitor how the equipments are moving in each of the hospital and how they are doing in the hospital. The other way we monitor, we have so the other way we monitor, we have what we call the Hadley monitoring system. So the Hadley monitoring system is also a system where all the equipment that we supply, if you allow us, we put something to monitor, and it's able to monitor the usability of that equipment, so that we know this equipment being used, and is it being used correctly? Is there power outages that are occurring? And you also monitor, the conditions, are they conducive? We are looking at the humidity of the place. It's able to monitor all that, the temperature and the humidity, and it's able to just make sure that we are able to track and see when the equipment goes down, how soon is it being worked on and getting up, and we are able to just look at the uptime for each equipment. And then the last thing that I would want, one of the last things to say is that other than those other than the many equipments we have been doing, we are currently funded by the Gates Foundation to scale up the use of CPAP and point-of-care ultrasound. And I was excited yesterday, we had a session on point-of-care ultrasound. So we are scaling up. We are scaling up 1,000 CPAPs and 980 point-of-care ultrasounds across different countries in Africa. Ghana is in phase 2. We are currently doing the phase 1 countries, and the phase 1 countries are Kenya, Uganda, Tanzania, Rwanda, Malawi, Rwanda, Ethiopia, and Nigeria. And then Ghana will be under phase 2. And that's why we are here to just find out what else we can learn from the Ghanaian environment. Yeah. So how can we work together with the Pediatric Association? We can work together through capacity building and education. We can look at the technical and comprehensive, basically supporting the technical, giving technical support. We do facility assessment, we do equipment assessment and the needs assessment for the facilities, but you also look at preventive maintenance and help facilities not to have a lot of equipment in the graveyards and being stored. And then we also can work together through monitoring and evaluation, which we have already talked about, how we can do that, and then how to sustain sustainability in terms of procurement. Those are our we work through distributors and those are our partners. And AHS is who we are partnering with in Ghana for now. Some of the equipments we have, there are many, they are available through AHS. These are just examples. We have equipments for respiratory support, equipment for jaundice management, equipment for thermoregulation. You also have equipment for fluid management. So we have fluid pumps, and then we also have hemoglobin testing equipment, and then the point of care ultrasound. Thank you.
Thank you very much. We'll postpone the first 5 minutes of questioning to the last session and have the last two presenters. So the fourth presenter is Dr. Pabi.
Thank you for the opportunity to present this multinational antimicrobial resistance surveillance. Lessons that we learned from Econ 2 site, that is a 37 military hospital here in Accra. And I present this on behalf of my other co-researchers. So this will be my outline. By way of introduction, we all know that globally, antimicrobial resistance is something that is of public health concern. As clinicians, we are all concerned, and as a patient, we are also concerned. Most data that is available usually is only on the microbiological isolates or data, and there's no clinical correlation with the microbiological resistance patterns that we tend to see. Due to low resources in our environment, we are not able to make the full use of cultures, because most of the time we hardly even do the cultures, and when we do them also, their yield is usually not that good. Now, the utility of that cultures is affected by some factors, such as the timing. And you agree with me that most of the time we do the cultures after we have started antibiotics. And so we are not able to get the right yield that we do. And even when we are able to do it, our contamination rate seems to be a bit on the higher side. And that is something that is well known in low and middle income countries. More so, there is paucity of data, especially in Ghana, about our local antimicrobial resistant patterns. And most of the time, we have to rely on literature from elsewhere. So we needed to get some local data that will help us in our clinical practice. So Econ 2 was conducted in 19 sites involving 9 countries, 4 in Africa, Ghana proudly to be part of those in Africa, and then in Asia. In Ghana, we aimed to roll out an integrated clinical and laboratory-oriented antimicrobial surveillance of hospitalized patients as part of our routine care. So it was just like monitoring our routine care at 37 Military Hospital and then at Kolebu Teaching Hospital. We therefore sought to provide real-time reliable clinical and microbiological data in order to guide our clinical practice and also to improve the outcome of our clients. So here today, I'm reporting from one of the sites, 2 sites in Ghana, that is from the 37 Military Hospital. So what did we do? A control study protocol was used in 2 pediatric and 3 adult wards at 37 Military Hospital from February 2022 to March 2024. Patients presented with infections who were prescribed IV antibiotics by the attending clinicians were screened and then enrolled into this surveillance after they consented. Even though it was just a surveillance, IRB or the ethical board required that we get consenting forms from those whose clinical data were going to be used. Clinical and microbiological data were extracted from the patient's notes and also from electronic medical records. So we took information by their demographic, the infection syndrome that they were presenting with, and then the empiric antibiotics that they were prescribed. Patient hospital outcome on discharge was also recorded, and then we followed them up on day 28 also by calling each and every one of them to find out their state if they were successfully discharged home. Data was cleaned and then standardized for descriptive analysis. So basically, this is the ACOM protocol that was used. So daily ward review of new community-acquired infections, which we define as a doctor suspected an infection, and so started IV antibiotics. Then we are interested in such a patient. We also conducted weekly ward point prevalence survey in order to pick up hospital-acquired infections, which we define as onset of infections greater than 3 days post-admission and start of an IV antibiotic. So if you're on the ward, probably you're not on antibiotics, but after 3 days, there's a need to start an IV antibiotics. Then we consider that you might have acquired a hospital-acquired infection, and then we enroll you as well. Then after enrolling, we follow them up, and then on discharge, we note the outcome, and then on the 28th, as I mentioned, we also place a call to all the patients we enrolled. Now, so what are the results? Over the period of 26 months, we enrolled 1,999 patients, and we had 538, that is 26.9 microbiological data. So it tells you that most of the patients, even though the clinicians prescribed IV antibiotics, no microbiological data or no microbiology was done for them. Out of the 538 microbiological samples that were taken, we isolated 69 cultures. And out of these cultures, we had 18 target isolates. The target isolates are isolates that are being surveyed by WHO in the GLASS system. Out of the 1,999, 66% of these patients were children. So heavily, a lot of children were coming in, but they were being prescribed IV antibiotics. These are the clinical infection syndromes, upper respiratory tract infections, sepsis, and lower respiratory tract infections that we managed. And then the commonest antibiotics that were prescribed, crystalline, penicillin, and gentamicin, which is our first line for pediatric infections in 37 Military Hospital, followed by ceftriaxone and cipro, mainly coming from the adult wards. Now, the blood cultures, we realized that there's 6.8% of the cultures yielded contaminants, whereas our positivity rates for microbiology isolates was 12.9%. Out of the total of 69 isolates, like I mentioned, 18 of them were glass pathogens, and most commonly isolated was Staph aureus, E. coli, Klebsiella pneumonia, and Pseudomonas aeruginosa. This is a sensitive pattern of Staph aureus that we isolated. Relatively, most of the antibiotics, they were quite susceptible to the antibiotics. So these are the isolate for E. coli and their sensitivity pattern. You can see that compared to Staph aureus, most of the E. coli were also developing resistance to most of the common antibiotics that we prescribe for our patient. And Klebsiella pneumonia, I'm sure we all know Klebsiella is a very notorious organism. From our survey, we realized that most of the antibiotics we're using were quite resistant, except for the carbapenems and then meropenem. Death was the outcome in 7% of the patients, and 23% of the patients were not back to their normal life after being discharged, and most of them were in the adult population. So from this, we realized that antimicrobial resistance surveillance, we found low culture rates and low yield compared to other studies. However, ours was also found to be lower than a meta-analysis from 12 African and Asian countries. The differences could be due to the study setting and then also the methodology that was used. The contamination rate in this survey was lower than in other studies, though we believe that it could still be better. From other countries, their contamination rate was as high as 25% and above. E. coli and Klebsiella and Staph aureus recorded significant resistance to the antibiotics that they were tested against in this study. Treatment outcomes were relatively satisfactory. Those significant numbers were not back to their normal life after being discharged. So in conclusion, the rate of antimicrobial culture requisition and its timeliness and yield to support clinical decision-making is scanty. Significant resistance is observed in the glass and microorganisms that were isolated. So in future, we hope that we'll be able to incorporate this ACON experience into our routine AMR resistance in Ghana, and then also build a whole genome sequencing infrastructure for antimicrobial resistance surveillance. And this is something that the project, that's the second phase of the project that is ongoing, training microbiologists to be able to do the AMR genome sequencing for the isolates that we get. So this is a team from 37, and then the national team that's on this survey. Thank you. These are some of my references.
Thank you very much. We have our last presenter, Dr. Haruna Mahama.
Evening, everyone. My name is Haruna Mahama. I'm a senior resident in pediatric nephrology at the Konfanochi Teaching Hospital. So I'll be taking you through this very key and nice presentation, a lifeline for little lives, a newly established pediatric hemodialysis center to bridge the gap in renal care. As you can see, the theme for this year is what? Universal healthcare coverage. So actually, we have started and we are praying and hoping that other facilities would follow suit. So when I started my residency program in nephrology, the most difficult part or task was when you diagnose a patient of having what? End-stage kidney disease, and you needed to what? Talk to the family. It was so heartbreaking because all what we ended up saying was that, unfortunately, your child would have benefited from hemodialysis or a kidney transplant, and we cannot offer such services in our facility. Few months ago, this was what we're always telling our parents. And it was like, okay, so what next? That's the question to ask, what next? Then you'd be like, okay, there are facilities outside the country that you can actually go and get the services from, but you needed to what? To pay. And we all know that in terms of affordability, most of our patients cannot what? Cannot afford. So So we were fortunate with the help of our HOD in the person of Prof. Entry, and then Dr. Mami Enima helped in the establishment of a new dialysis unit. So as we can see, chronic kidney disease in children is on the upward rise globally, currently between 15 to 74.7 cases per million children. And data actually says that there is underreportation of these cases because we are not able to diagnose them early. When you come to Ghana, like my previous colleague said, there is a lot of positive data. We Ghanaians don't publish. Like I always say, we don't like to put out what we are actually doing in our facilities. We do a lot of work, but we fail to bring it out. And that is why most of the time it's very difficult to get data to speak to. Currently, in Konfanochi, when end-stage kidney disease, as at last 2023, we had about 13 cases. Just look at the numbers. 2024, almost double of the number of end-stage kidney diseases. So previously, we would have just told them that unfortunately, you needed hemodialysis, but we can't offer that care. But now, fortunately for us, we are able to offer that care. This was a study that was done by our own adult nephrologists in Kumasi, Dr. Elliott, and other senior nephrologists in Accra. So as of 2022, hemodialysis had actually been practiced in the country for 50 years. So they wanted to assess, to know the number of centers that are actually undergoing this practice. So throughout the country, sorry. Okay, so throughout the country, as at 2000, please can you go back? Okay, as at 2022, we had just 51 hemodialysis centers in the whole of Ghana, 51. And these 51 dialysis centers were located in just 9 out of the 16 regions, and only 40 were functioning. Just imagine, only 40. The remaining 11 were either shut down or they were yet to operate. And then out of those that were functioning, 65% were in Accra. And then 17.5% were in the Ashanti region, Kumasi. So the rest, 7, each of the other 7 were in one of the other regions. So you can just imagine that. So with the population now, if we are just relying on just 40 as of 2022, that should tell you that there's a big a gap. And then the private sector actually does very well because they were actually taking twice as many HD centers as the public center. And as at the time the study was done, they had about 1,195 patients who were receiving hemodialysis, giving a prevalence of 38.8% per million population. And out of that, 50.9% were in the private sector. Now, the question is, how many of our patients can afford dialysis in the private sector? And mind you, this data was largely on adults. None of the centers were actually demarcated for children. And look at the cost. So I'm just trying to evaluate the clinical and operational performance of the newly established unit, and then to look at the patient outcomes there. So it's a descriptive analysis, a 5-month period. So we actually started in September 5th last year, and then to January 31st, as at the time I was collecting my data. It's a 2-bed capacity unit with 2 friendly, pediatric-friendly 5008 hemodialysis machines. Initially, we had just 2 renal nurses. Now we have about 8. And then it's being operated by our pediatric nephrologist in the person of Dr. Inima Safu, and assisted by the 5 pediatric nephrology fellows who are currently under training. All right, so this is the unit. So you can see this is the entrance. This is the 2 machines over there. So this is our first patient on the 5th of September who was undergoing dialysis. All right, so far we've had about 227 sessions, and then averagely each of the patients undergo 3 sessions per week. This is the distribution. We currently have about 8 patients, 5 males and then 3 females. All right, so with the courses, this is also another problem because now most of the courses of our CKDs are what? Unidentifiable. So we have CKD of unknown origin. Just 2 of our patients that had serious resistant nephrotic syndrome. And then disease-related complications, most of them had anemia, hypertension, and then also pulmonary edema with successes. So we've been able to, since we started, 2 of our patients have returned to school. We've had 1 successful kidney transplant for 1 of our patients. And then also currently, we are working up 3 patients to also undergo kidney transplantation. With our challenges, yes, now the center is there. It is accessible, but these are the challenges: long distance travels and financial constraints. As at now, 3 of our patients are not from Ashanti region. 1 is from central region and 2 are from the western region. Okay, so with recommendations, we just want to emphasize that we should try as much as possible to educate people, try to have a preventive care so that we don't get to the point that they will need dialysis. We also want to ask for proposals for scaling up similar units in the country, build human resources, and then explore the need of chronic peritoneal dialysis program. Actually, this is very, less expensive compared to hemodialysis. Other countries are doing it. Why can't we? And this is what we want to plan to do. Pediatric kidney transplant program, now that we've started, we want to have a formalized program so that we'll be able to undertake this successfully. We also want to advocate that we start and get a pediatric kidney, registry. So throughout the country, we don't have a registry. So it's very difficult to come by data. And I think if we have a pediatric registry, kidney registry, be able to solve some of these problems. So this is the pioneering team. The first day they did the dialysis. This is my conclusion. So the center has brought a new wave of hope for children with kidney diseases in Ghana. And therefore, we want to call for continued investment, research, and partnership to sustain and expand this service. Thank you very much.
Well, yeah. We do everything for questions.
Let's take the questions.
So thank you very much to all our 5 presenters. We have 10 minutes for questions, please.
So if you want to ask a question, you can raise your hand. You tell us the presenter to whom the question is addressed and then ask your question.
Thank you. My question goes to the e-health, electronic. But the question is, I was expecting that Kolebu should have been the best place to be using the e-health system. So I wonder why the paper base is higher than that of the electronic base. Please, can you research further? Why? Because at least all the people at Kolebu, everybody's IT at least. You are computer literate. So why? That is the easiest, because normally when you are doing the public health research, we know that if you have the e-health, once you get into the system, any data that you want, you click a button and it pulls it out for you. So you can do the better analysis of disease trend that is going on. So the question is why?
And we'll take 3 questions and then.
As a follow-up, I was wondering whether at the time that the period they took the data, was it at the time that they were now introducing the electronic medical records, or it had already been established? Thank you.
Have you noted the 2 questions? They are both yours. 3rd question. Any other questions? Okay, you can answer.
Okay, so the study was done 10 months after, I mean, the data set picked was 10 months after after the transition. Yes. So it was they were introduced in 2021 September. We did the study. I mean, we did the study recently, but then we took data from June 2022. And this would serve as baseline as well. So we would have to we're still analyzing this data, but when we're done, we'll probably do another one to see some years after how it's going. Yes.
Okay, so he's suggesting you should do a qualitative study to find out the reasons why the completeness was so low. Any other questions for the other presenters?
For Matilda, I think your first presenter. The title of your study got me a little bit confused because it was a pilot study on patients sourcing care outside of the teaching hospital. So I was waiting to hear the part where the patients were actually referred out of the hospital for their experience, but it looked like it was just a survey of their willingness to accept that. So I don't know, I just felt like maybe just for learning purposes, maybe bosses can talk a bit more, but I just thought the title was a little inappropriate.
Thank you very much. So Dr. Kilby, I had a similar thought as well, but I think in my mind, I felt that what she was suggesting was that they are initiating a pilot with the hope of expanding it subsequently. So that's my understanding of this, but you can probably give further explanation to it. My substantive question is to the presentation on the AMR as well. So from my understanding, it seems that you are doing more of a clinical audit, because you're intending to institute some measures and then you reassess it. And it comes back to the use of the titles that we are using. There was also a study that we said, or the original title was a case study, and then subsequently you said it was a cross-sectional study. So in one same study. So if we can be clear about the titles of the studies that we are doing, because these are scientific things and the expressions are targeted, they are not vaguely used. Thank you.
My question is for the last presenter on the hemodialysis. You mentioned that I think majority of those on dialysis, you could not identify the cause of their kidney disease. Is this after everything, they've had a biopsy done, all the extensive testing, or within the limits of what you are able to do?
Okay, so we'll have the presenters respond.
The presenter wants some clarification from Dr. Dela.
Please, when you were referring to the case study versus...
That wasn't your presentation. That was the inhaler technique. The first question is addressed to the willingness to accept referrals. Yes, so you attend.
Thank you. So the study, like we said, was a pilot study to assess the willingness of caregivers to receive specialty care at other facilities other than Korle Bu Teaching Hospital, because of the fact that when they come to Korle Bu, because of the large numbers we see, the waiting time is prolonged and patients are generally not so satisfied with the service we render. They stay there for so long before they are seen, and then they go back home. So that was the whole concept, to assess whether they would be willing to go elsewhere, and then also to look at the waiting times. But then again, it's a pilot study. We are still going to develop it further to later on, maybe in the future, to assess other factors that would contribute to patients seeking health care. Maybe let me say Korle Bu because that's where we are. So receiving healthcare in Korle Bu and then other associated factors to assess the quality of service that we give to our patients. So basically, it's like a patient quality survey, but it's in the pilot phase. We are yet to escalate it.
Thank you very much. Any other one?
Okay, so the one on, I think we did a case control study, and when you were analyzing, you analyzed it as a cross-sectional study. Can you explain that?
Thank you very much for the question. So the initial design of the study was a case control. That was the idea we started with. But after we got the data and we're looking at it, we realized that we could also assess the inhaler device technique used. So we decided to just focus on that one and then analyze it and just do a descriptive analysis. So that's why we said at that point that because we're just looking at that one, and we also didn't, at the time that we're collecting the data, we did not match the case or the control using that variable. We decided to look at it as a cross-sectional study. I don't know, I hope I've not confused anybody. So we may do further analysis, yes, because this is just a descriptive part of the data. So you might have to do analysis, and that's where you might have to be looking at the factors and all.
Okay, so we any more questions before we take our final remarks? The 10 minutes is over. Yeah. Okay, so just some.
Okay, so we'll give the
yeah.
professor's wife the last.
I think there was a question about the last presentation about the causes of.
Okay, so, all right, thank you for the question. Yeah, so we do kidney biopsies at our center. Yes, and sometimes we don't find that. I remember we needed to do a project, and like I said, we have something we call chronic kidney disease of unknown origin. Yes, so I teamed up with one of our pathologists in Confanochi Teaching Hospital, where cases that were children that were diagnosed of CKD, when they passed, we tried to do even some of the biopsies, how do you call it? We take samples, do histopathologies and all that, but still, we even tried to test for heavy metals and all that because of the galamsey issues and all that. Some of them just come clean and you're not able to identify. So that is why there's that new term in the blog called CKD of unknown origin. Thank you.
Okay, so the chair has asked me to give the last opportunity to her.
Thank you very much, Madam Chair, and kudos to the renowned team. My question goes to you, Dr. Mahama. There are advocacy groups around and sponsors around, and as part of your challenges, you stated that there's financial constraint. Can you tell us how much a session costs, or say they have 3 sessions per week, how much it costs? Yeah, thank you.
Thank you for that last question, and thank you to all our audience and to our judges. So please answer. We'll take a word from the judges and then we will give the results.
All right, thank you for the question. So a session costs 850 Ghana cedis. 850 Ghana cedis. And then the health insurance takes care of 491 Ghana cedis. So they pay the rest, almost 360 Ghana cedis. Thank you. Okay, so a follow-up question, whether it's covered by insurance, it's not fully covered. So like I said, they take part and then the patient also puts the rest. No, so I said a session is 850 Ghana cedis. Health insurance takes care of 491 Ghana cedis, and then the rest is borne by the patients. Fortunately for us, 3 of our patients are on sponsorship, and that is why they are able to do it very well. 3 sessions.
Lifetime sponsorship.
Yes, please.
Thank you very much to our 5 presenters and to our 3 honorable judges. So I'll just give a summary. Our first presenter just gave us a few take-home message that we need to take care of our referral pathway, try and downscale, empower our satellite preparing hospitals who have pediatricians to be able to set up clinics so that after the teaching hospitals have stabilized the patients, we can down refer some of them for follow-ups there, since the patients are happy to accept that. And also that will reduce our patient load and then their waiting times as well. For the second presenter, what we got from her presentation is that we need to take a closer look at our EMR, electronic medical record system, which is now the in thing. And we are hoping that their second study will provide us with more answers to be able to help us all better our record taking for future studies. And then the third presenter, her take-home message was that we should pay more attention to our asthmatics when they come in, assess their inhaler techniques all the time. What we didn't know were the reasons why, whether these caregivers were the original caregivers who were trained to help the children, or whether they are step-in caregivers, we don't know. When they last had an inhaler, training session, we don't know. So we are hoping that your subsequent study will provide us with more answers. But then the fact still remains that most of our patients are not using their inhaler techniques very well. And then from the fourth presenter, we still have a problem with our antimicrobial stewardship. We are prescribing without taking cultures. But the good thing is that our contamination rates are low, so that for the ones that we are taking, we are doing them well. That's as to why we have low culture rates, we don't know. Maybe it's good for us, or maybe there's something more to be done. We wait for the subsequent results of that study as well. And for our fifth presenter, Dr. Mahama, you have given us light, hope at the end of the light at the. You've shown us the light at the end of the tunnel, and in keeping with our team, I think that you've given us hope. Little by little, we'll be able to bridge the gap and give all our children a new lease of life, make our families happier. So the final word will go to come from Dr. Armstrong.
Right, good evening, colleagues. Thank you very much for giving us the opportunity to judge our presenters. Myself and the other 2 colleagues, we believe we've been fair and accurate, and we hope that our verdict will match your imaginations. Thank you very much.
Okay. And then before Yakubu gives the results, I would encourage all of us for our next AGSM to make it a point to bring in more papers for us to know what we are doing, to encourage us all, to help us all better our practices, and then know what steps to take when we leave as a group. And so, over to you.
All right. Thank you very much, Madam Chair. And thank you to all the presenters, the audience, and the judges. Over the years since we started presenting abstracts, we have been getting increasing number of abstracts year by year. This year, we got a total of 30 abstracts, which is the highest in the past 3 years. Of the 30 abstracts, we accepted 24, rejected 6 for various reasons, but they were all good studies. So congratulations to all of us. And I hope that in the coming years, we'll have more abstracts being presented, and then we'll allocate more time for their presentation. So all who have presented abstracts stand a chance of winning some prizes. And I have the results here with me. Even though you all did very well, the first 3 in the poster presentations and the first 3 in the oral presentations will go home with some prizes. So this year, the first prize in each category will be 1,500 Ghana cedis. The second will be 1,000 Ghana cedis, and the third 750 Ghana cedis. So I must say that it was keenly contested, and after compiling the results as the chief returning officer of the abstracts, the first, let me start from the third. The third in the poster presentations was annular pancreas presenting at 3 weeks. Who presented the annular pancreas presenting at 3 weeks? Second poster, detecting intravascular hypovolemia using IVC diameter to height ratio in children aged 2 months to 5 years. And the third, trends and patterns of child sexual abuse presenting at the Ghana Police Hospital. Okay, so that was keenly contested, and I must say the difference between the second and third was 0.1. All right, so yeah. All right, so but the 0.51 is a big difference. It separated them. Now for the oral presenters, the first was the third. So the third, willingness of caregivers to accept care in other facilities. The second, completeness of emergency medical records. And the first, inhaler technique. Okay, so we hope the judge's verdict matches your imagination. All right, so let's have the award recipients here. You take a picture with the judges. So come over here. You take a quick picture. Come down. Okay. Let's go. The co-authors can join. All presenters. Okay, thank you all very much. And I will encourage us all to present abstracts next year. It appears the most frightened of them were the ones who won the awards. So the first three presenters said they had never done this before and they were frightened, but you did very well. Thank you all very much.
Yakubu, you are the one closing us. Yakubu. Oh, sorry.
Thank you very much, Dr. Yakubu.
Okay, so we will have the chair of the LOC give us the closing remarks, and then we'll take the the vote of thanks and closing prayer. So Dr. Beatrice Nan, chair of the LOC. Beatrice. Please come. Okay, let's give her a round of applause.
Oh, I see. So this is ambushment. Oh, really? Okay, after that, okay. So good evening to you all. You'll all agree with me that it's been a spectacular AGSM. We deserve a round of applause, all of us. It's been wonderful. Even though the road leading to this climax has been difficult, but God has been good. And they said that all is well that what ends well. So we thank God and we thank all of you for making this day possible. When I was given this task to do, initially it seemed I should couch it well. I'm somebody who likes taking up challenges. So when I was given the role, I thought, okay, I mean, I have strong women. We have the women and the men, so we can do it. But when we started, amidst election fever, donor fatigue, change in government, it was challenging, it was difficult. But we had a goal, we had a target, we had a vision, and we had in mind how we wanted this AGSM to look like. So we were resolute, steadfast. I missed all the challenges. I missed all the emails stating that we can't help you. Sorry, we can't help you. Sorry, we can't help you. We kept focused. And by God's grace, it's been good. It's been wonderful. I think we should clap again. And I want to call up here all my able women and men. I say we have the women, but we have the men also. So I want to call up here all LOC members, ad hoc, full members, partial members, absentee LOC members, everybody whose name was on the list but didn't show up. Everybody should join me here. Let's just acknowledge the team that made this day possible by God's grace. So all LOC members, they are not expecting it, just as I was also knowing. So let's all come up here so that we see all the 18 members that I worked with. Sefako, fantastic with the media. We flooded all our platforms with posters. You couldn't even find which one was the one relevant to the day you want to. There was a plethora of advertisements, ads, side attractions, pre-conference, team members, transport officer, where the hospitality team, Deputy Minister of Finance. Where's the Minister of Finance? Minister of Finance, Minister of Finance. And Honorable August, President One. President One. Souvenir champion, Genevieve. Hey, Deputy Minister, Deputy was President, Vice President. I think we had some ad hoc members as well, but they are not here. So these are your LOC members. They've worked very, very hard. Tireless calls. It's time for meeting, then we put the emoji running on the page, run for the meeting and all that. So thank you very much. You worked so hard. I've always used the word A-team, and indeed you've proved yourself to be the A-team. So we thank all of you, judges that we called last minute, people that had to help. Without your presence here, those who submitted abstract, without your presence here, this day would not have been possible. Tomorrow we have a business meeting. So the AGSM is not over yet. There's another day that is tomorrow, and to be quite a short day. So we are hoping that the next region that is going to host the AGSM, look, we have raised the bar. You have a uphill task, but we know that we are all one team, and we are also going to deliver next year. So thank you all very much for coming and sticking and staying to the end. God richly bless all of you. Our media, the vote of thanks will come. So God richly bless all of you.
So we'll have Dr. Ejewa Boniede give us the vote of thanks. So please, after the vote of thanks, we all come up stage for a group picture. It's very characteristic of our AGSMs. We always take a group picture. Thank you so much.
Good evening, all. I was hoping I could escape because I think my LOC chair has done justice to the vote of thanks. It's been a long day, but a very fulfilling one as well. And we are grateful to God for his goodness and for his unfailing blessings. On behalf of NEC and the LOC, I wish to say a very big thank you to the chairpersons of our various sessions. We thank our panelists, our moderators for the very interesting and thought-provoking panel discussions. Thank you to our oral and our abstract presenters. Kudos to your hard work. It has paid off. And of course, our hardworking judges, we are grateful. We also thank our sponsors and our exhibitors. They made it possible. And finally, to all of you seated here, in fact, this AGSM would not have been successful without you. Thank you for your enthusiasm and your participation. It has been palpable. Thank you to you all, and God bless you.
Thank you for thanking us. So we'll take the closing prayer, and then we'll all come up stage to take a picture. Shall we please be on our feet as we pray? Our Heavenly Father, we are most grateful unto you for your gracious mercies unto us. You have been with us all throughout this program, and you brought us to a very successful end and fulfilling one as such. We pray that you continue to guide and guide our steps in every way that we go, and hold our hands and continue to make us champions and advocates for our children. We thank you for blessing PSG and our nation, Ghana, and the world at large. In Jesus' name, amen. All right, so please come up stage, and then our photographers will help us to take a picture. The boy children will please help us to take the table away. Please don't run away. This picture is a very memorable one. It will be trending for some months to come. So please don't run away. If your height is like mine, please stay in this line. Madam President to be in the middle. Madam President to be in the middle, and then we will flank her.
Please, you are waiting for all of us. Hey, 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 no, please come here. Please come here, please come here. When we are done with this, we can take more pictures. Please come up stage, come up stage. We don't want to see anybody here. Please go up stage. Our bosses.